Ladies and gentlemen, good morning and welcome everybody to this meeting in public of the Board of NHS England. Very warm welcome to those who are joining us here in London this morning and also to that vast audience who watch the live stream and follow the decisions of the board. I make this point because the board meets in public. It's not a public meeting, but we meet in public because we do actually believe that important decisions regarding the operation of the NHS in England are undertaken in public, visibly and transparently. So this is our invariable custom. But by the way, to stress also that this is not the only way in which the board does business. We do business through committees, and there will be later on in the agenda today the reports of committees to the board as a whole. We do business also in a private meeting. At the end of this meeting I will resolve to go into private meeting because for statutory reasons there is business of a commercial character or of a personal character which we need to conduct in private. We also do quite a lot of work, by the way, in strategy mode, thinking through at a relatively high level of steps that we should be taking across the NHS and developing policies that then can come to the board finally for approval. So that's the context in which we operate, and it's part of our commitment to openness and transparency in the way that we work. I should also emphasize today, in case there's any confusion, that the volume of papers that's coming to the board today, I've counted at about 1,000. The fact that not everybody's got them powered up in front of them is due to the fact that we're using software which allows us to consult them on laptops and iPads. But I will be ensuring, of course, as we go on, that the board is fully conversant with all the paperwork that's coming before it. One process issue just to raise with you along the following lines. There is no fire drill scheduled during the course of the next 2 or 3 hours, so should the alarms go off, our staff will guide everybody off the premises to a safe place. So, I now want to formally open the meeting, and first of all to welcome a new member of the board, who is Emily Lawson, who's our new National Director for Transformation and Corporate Affairs, who has joined us with effect from the 1st of November. We have, since the last meeting, appointed a successor to Sir Bruce Keogh, Professor Steve Powers, who will join us from the 22nd of January, will be our new National Medical Director. I do, however, wish to mention in context of that this will be Sir Bruce Keogh's last meeting of the board. He has retired from the board with effect from the middle of January in order to take up a new position as chairman of the Birmingham Women's and Children's Hospital. And there will be other opportunities for me to express our enormous gratitude to Bruce, but all that I would wish to say today is he's one of those most unusual people whose achievements hugely overshadow his ego, and he's made an enormous contribution to the NHS in England. Thank you, Bruce. I should also like to record formally, since the last meeting, the appointment of one of our non-executive directors, Sir John Byrne, to be the new chairman of the Newcastle upon Tyne NHS Foundation Trust. I think congratulations are in order, John. And you have our very warmest best wishes for every success in that role. Two things flow from these two appointments, by the way. First of all, I'm going to ask the board to endorse a simple transfer in committee representation, which is that John will stand down from Specialised commissioning, given the extensive investment by that committee in the Newcastle Trust, and will instead join our Audit Risk Assurance Committee. And secondly, that for today, when we have an important item coming up on congenital heart disease, I think it's important that we should ensure that there is no possibility of conflict of interest. Bruce Keogh will introduce the paper, but then he and John Byrne will leave the meeting because of the relationship, first of all, of Newcastle, and then secondly in relation to one of the hospitals which is under consideration on congenital heart disease has an interrelationship with Birmingham Children's Hospital. So we will deal with that when the moment comes. I will also in a moment ask my colleagues to declare other interests which they may have in business on the agenda today. But before we do, I would like to, on behalf of the board, issue a very warm welcome to the new Chair of NHS Improvement, Baroness Dido Harding, and to the announcement yesterday of the appointment of a new Chief Executive to NHS Improvement, Ian Dalton. Ian was formerly Deputy Chief Executive of this body, and we look forward to working very closely with both of them. I can assure the board that I have worked already very closely with Baroness Harding. I want to ensure that we as joint chairs share responsibility for the work of the NHS across the two bodies, and our determination as far as possible to bring the working of the two bodies closer and closer together so that there is a single voice of national leadership for the NHS. So let me then at this point invite any declarations of interest from members of the board, otherwise than those that are on our standing register of interests.
Michael, I should say I'm a chief investigator on a national trial which involves all the major academic centres, so I have an interest obviously in the applied research in the NHS, but I'm very keen to be involved in the discussion.
Right, I don't think that's a disqualifying interest. Anything else? No? Right. Let me move on. We have the minutes of the last meeting. Can I just check that they are a fair and accurate record? And I have no matters arising from the minutes. Is anybody else? No? Fantastic. So the next item is the Chairman's report, which I shall make briefly. Just to report, first of all, on various aspects of activity. As you would expect as Chairman, I have spent considerable amounts of time in meetings with other arm's-length bodies, chairs. I have done some visits to hospitals, including King's College Hospital, London, including York Hospital. I have visited STPs in Surrey and elsewhere, and I have been on a number of platforms speaking. One particularly important one, as I recall, which was to the Local Government Association and Adult Social Services Directors Association in Bournemouth, where we had a discussion about our joint and shared responsibility for reducing delayed transfers of care in our hospital systems. With Sir Bruce, I have had meetings with the Academy of Medical Royal Colleges to try to ensure that we are closely aligned in what we're doing with their ambitions, and that we are able to identify actually a number of key strategic issues where we simply have to be better joined together. And then finally, as a member also of the Board of Genomics England, this, by the way, is a company, but it's wholly owned by the government, through which we are trying to establish the NHS as the world leader in genomic medicine. And it's, I think, a successful partnership, but not without some very serious challenges, which are almost inevitable when one is operating at the very cutting edge of science and technology and clinical expertise. So I'll conclude my report at that point and invite Simon to before I invite him, I ought to just suggest, are there any questions, queries, criticisms? No. Right.
Of you or me?
Your turn is coming. Right. Let me pass over to Simon.
Okay. Thank you, Malcolm. And given our packed agenda, I'm just going to talk about one thing very briefly, which is our winter preparation. As we've talked about as a board previously, there's an enormous mobilisation going on across the NHS. We were fortunate to receive additional funding in the budget for winter, another just under 350 million. And so over the next 10 days, Pauline Phillip, our National Emergency Care Director, is in the process of working out with local hospitals and community services and GPs and other partners how best to deploy that to try and make sure that we have the best preparation that we can. I'm going to ask Bruce in a moment just to kind of give his point of view as the chair of the new National Clinical Escalation Panel on how he thinks we are positioned for winter. But I think the message to the public is that there is still time to get your flu jab, hence these various posters around the room. It's pleasing to see that the uptake of the flu jab this year is higher at this point than it was at the same time last year. That's true for older people, it's true for vulnerable adults and children. It's also true for staff across the NHS, and NHS England is for the first time making available £10 million for vaccination for staff in care homes as well. So good progress being made, still time to make a difference. We'd urge everybody to do that.
Could I just add, the entire board has had their flu jab, or will have had by nightfall.
Personally administered.
That's right.
Indeed.
And so, Bruce, did you just want to comment on our...
Simon, I don't think I want to add a huge amount. This is the 11th winter that I will have been involved in since being National Medical Director. And I think it's the one that we're best prepared for. Historically, we would start preparing for winter around about July, August. This year we started really from the end of last winter. We've engaged a lot of people in discussions on how best to approach winter. We've received that. We have, I think, a good plan. So for the following wind, I would hope that winter will go okay, but there are a couple of points I would like to make, is that every winter is unpredictable. It's unpredictable in terms of the impact of flu virus, and it's unpredictable with respect to things like norovirus. So there are still things that can knock us off course, so we have to be remarkably vigilant. We have a panel which will be looking at this stuff, as you've already mentioned, over the course of winter. And I guess two other remarks. One is, I think we need to be really clear about how staff in the NHS over winter go the extra mile. They always have done, and I'm sure will always continue to do. And I think we all, because we'll all suffer something over winter, we owe them a debt of gratitude. And the second point I'd like to make is that given that a significant proportion of flu is transmitted by people who don't know they have flu, may even be asymptomatic, I'd really encourage not just the citizens of the country to have flu jabs, but in particular members of staff, because we need all hands on deck in the NHS over winter, and if we can just keep our staff safe by flu vaccination, that would be really, really good.
Thank you.
Right, any other questions, queries for the Chief Executive? No. Good, thank you very much. We move then on to the next item on the agenda, which is NHS planning for 2018-19. And before I invite Simon to speak to the paper, I thought it might be useful to have a few prefatory remarks on two facets. First, to draw the board's attention to the responsibilities that we have as the Board of NHS England as a consequence of the 2012 Health and Social Care Act, which for the first time disestablished the NHS's leadership as a function of the Department of Health and transferred it to an independent arm's-length body, in those days known as the National Commissioning Board, and now more commonly known as NHS England. Now, the significance of this, colleagues, is that the statute puts the duty on us to promote in England a comprehensive health service designed to secure improvement in the physical and mental health of the people of England and in the prevention, diagnosis and treatment of physical and mental illness. So there's that primary statutory duty, but there's a whole lot of other statutory duties that come in behind that, around the duties to promote integration, to promote research, and to promote equalities, all of which will come up elsewhere on our agenda today. So Parliament's actually made it very clear that these are not responsibilities to be shied away from, but to be dealt with as our normal course of business. So the arrangement, which is set out, I think, well in the paper, is that it's of course, the responsibility and the function of government to determine the volume of funding that should go into the NHS in any given year. But our responsibility is to ensure that those funds are used in such a way as to deliver those outcomes for patients that are defined in the statute. And I would put it in this way, that our function is actually one of stewardship of scarce public resources to get best benefit to patients and to the public that we serve. We're not a political entity, we're not politically aligned, and indeed actually that independence is a very critical part of our raison d'etre. So I would also, I think, suggest that money is not our only resource. I think one of the great resources of the NHS is the staff, and actually the great voluntary movement that wraps itself around the NHS and helps our colleagues to deliver in the way that they do. But we're not sovereign. We operate within quite a complex network of relationships. We have, obviously, the relationship with the Secretary of State and with the Department of Health, which is absolutely critical to the way that we work. It operates in two ways. There's this very formal mechanism that we'll talk about in Simon's paper, which is through the mandate. So the legislative theory of Parliament was that the board would be set up independently, that there would be every year a mandate created by the Secretary of State and laid before Parliament, which would be our objectives for the coming year. That's a formal process, but of course it's underpinned in practice by an array of informal, operational relationships, which means that we have the ability to work closely with the Department and with the Secretary of State in a cooperative way. But there are always difficult choices, and there will be difficult choices again this year, in which the board must be independent in the advice that it gives to government whilst committing itself to working closely with them. Our other interdependencies are also pretty significant. One of them is with the other arm's length bodies, and in particular, obviously, with NHS Improvement, which I mentioned in my opening remarks today. But beyond that, Parliament decided that although the budget for the NHS in England should largely come to NHS England, the bulk of it, like about over 70 billion or 65% of the budget, is allocated by us out to CCGs. They commission the bulk of healthcare provision in England. Over them, we have a supervisory responsibility. We allocate the resource, we oversee their planning, we monitor their performance, and we work closely with them. But when it comes to the actual allocation of resource into commissioning, particularly into secondary care in our hospitals, it's the CCGs who are in the driving seat. We have huge responsibilities ourselves directly for primary care and also for specialised services, but this is a complex network through which we work. So I just then want to move to one, I think, correlative issue, which is what I would call the black hole hypothesis. And by this I mean the assumption that sometimes is made that when money is allocated to the NHS, it goes into a black hole and nothing is seen to come out the other end. I think it's very important in this context to emphasise the extraordinary productivity of the NHS. If we look at the data over 2009 to the current year, we can see that the per capita increase in spending in the NHS, that's per capita for each of the population that we serve, has gone up by about 3.2% real over that time. But what's the productivity increase? It is in A&E attendances, 7.7%. In non-elective emergency admissions, 6.7%. In elective admissions, that's day case and overnight stays, some 15.7%. So we can identify a rolling productivity improvement in the NHS of around 1.8%, is it, Matthew? 1.7% per annum, which, of course, far outstrips productivity in the general economy. So I think it's tremendously important in the context of the responsibilities that this board has to understand what extraordinary change is underway in the NHS. And it's not just the dedicated workforce to which we always owe a great debt, but how we can improve the quality, the models of care, and the other ways in which we can deliver our services. Those will come up in Simon's paper. But I hope that the board is content with its understanding of our responsibilities today. May I then invite Simon, please, to speak to the paper.
Okay, thank you, Malcolm. We're going to divide this up between us. The budget for the NHS having now been set for next year, our aim is to get the best possible health service we can with the money that will be available. So the way we're going to approach this discussion is Paul Bowman is just going to remind the board what the budget outcome means for the NHS next year. I'm then going to ask Matthew to talk about some of the actions we're going to take to get the best we can out of the pounds we've got. And then even when we've done that, there are still going to be some tricky judgments that we're going to have to make with our partners, with other bodies in the NHS, with the Department of Health working together on what the right combination of services looks like for next year. So that's what we will be going on to talk about. But perhaps, Paul, you can start by just setting out the budget outcome.
Indeed, just a quick reminder, because I'm sure members of the board will already have pored over the Red Book and all the other exciting documents around the budget with their usual diligence. But the recent budget provided an additional 1.6 billion of NHS revenue funding for next year, as well as 354 million of publicly funded capital resource. Both are important. We're going to focus today on the revenue aspect, but clearly there are some important decisions around capital also to be made. With that extra 1.6 billion, the total NHS revenue budget will now be 113.4 billion in 18-19. This is equivalent to real terms growth of 2.1 billion, or 1.9% for those of you who prefer percent, which follows growth of 2% in 17-18 and 3.1% in 16-17. But perhaps the most relevant statistic is the one which sounds most boring, the age-weighted real terms growth per head number, which effectively factors into the calculation both inflation and the growth in the population and indeed the profile of population. And the salient point, the salient statistic therefore for 18-19 is 0.9%. That's the money that we've got over population and inflation, as measured by general inflation, I would say, rather than NHS inflation. So the important question really is, so what does that buy us? And that's essentially the conversation we're about to have. The additional funding is obviously helpful, given the very significant financial and operational pressures that we face next year. But even with some pretty ambitious assumptions around efficiency, our assessment, based partly on the earlier work we've done on the 5-year forward view a few years back, and then on our assessment of the more recent developments in the financial fortunes of the NHS, is that it won't enable the NHS to deliver all of the expectations which are placed upon it while living within its means. So inevitably, we face some significant challenges in squaring that particular circle over the next few months. And it's that which we're going to focus on, I think, in the rest of the discussion. And Matthew, perhaps you can pick up the strand from there.
Thank you, Paul, and thank you, Simon. I think the first thing to say is just to reiterate Malcolm's point that the NHS has been making a series of actions over the last 10 years and probably increasingly quickly over the last few years to drive our own productivity. And that 1.7% per annum productivity growth is an impressive performance, and does mean that we continue, even as we struggle every day to make sure that we maintain the shortest possible waiting times and the best possible A&E access. We have access times which are extremely impressive compared to other similar countries for a lot less money. So if we compare ourselves to places like France and Australia, we spend a lot less on our healthcare system and provide better access, faster access to care. But as we move forward, we need to keep that going, and we need to do more. And I guess that the first obligation on us as leaders of the health system is to say, are we spending every pound that we get as effectively as we possibly can? Are we delivering the most health that we possibly can out of that? And we've seen the productivity gain that we've had over the last few years come I think, from two separate things happening. One is we are putting more pressure on our staff. So we can see whether it's in ward-based hospital nurses or staff in our A&E departments or community nursing services or our primary care services, people are being asked to work harder and work faster, and they are feeling the pressure of that. The second thing we've done is that we are changing the way that we deliver services, so we are getting a significant improvement by being by the new models of care that we've been putting into place, so that we can see that in where we've been doing our innovative programs like the Vanguard's programs, we're seeing a much slower rise in the hospitalisation rates. We can see that in our accountable care systems, where the systems are working closely together, and we're moving away from institution-based view to a patient and population-based view of how do you design healthcare. We are seeing demand being mitigated, and we're seeing cooperative working and more innovation in terms of how we meet the public's needs. And we've seen that the work that CCGs and GPs have done have caused an actual reduction in the number of referrals into outpatients this year, compared to a 3 to 4% historic increase every year. So it's not just about working harder, it's about working more effectively and using our talents more efficiently. And as we go forward, it needs to be more of the latter and less of the former. It needs to be more about how do we improve the way we run our services to use our skills most effectively, because most of our staff are working at the limits of what we can reasonably expect. So we will need, in order to meet the challenges of the budget going forward and to make sure the public get the most that they possibly can, to ensure that we leave no stone unturned in terms of the changes we need to make in the NHS to get the best value out of what we get. When we also need to look at the cost of running the NHS, and as the analysis that we have shows that for every pound the NHS spends on healthcare, we spend about 2p on the administrative costs. That compares with 5p in Germany and 6p in France. So we have a low overhead NHS, but it's not as low as it could be. And as we move forward with changes in reducing fragmentation, reducing competition, and to a more integrated system around STPs and ACSs, we would expect to be able to release some cost of management to be able to spend on more healthcare, to be able to turn the cost of administrative overhead into money that we can spend on clinical services to the public. And within the constraints of what the legislation says about the various arm's length bodies, we need to push as close as possible to integration without being in breach of the legislation. So we will be doing that as well, and working with our partner organisations to say, what are we doing that we could do more efficiently? But even after we have redesigned our services, even after we have turned over every stone, as we will continue to do, even after we have reduced our administrative costs, there are going to be some really difficult decisions that we need to make sure that the services that we deliver can be done within the money that we're allocated. And I guess that's the conversation we're going to need to have over the coming weeks.
Thank you, Matthew. So, having done those things, put those actions in train that Matthew said, we've obviously still got a discussion to have in partnership with other parts of the NHS, with the Department of Health over the next 4 months. And so we are proposing 5 considerations that should support that discussion. And I'll just briefly kind of explain why we think these are considerations that we need to all have in mind. The first is that, as Paul will report later on in this meeting, in the CCG sector and indeed in the trust sector, we are providing care at a higher rate than is currently being funded this year, to the tune of about £500 million. And we think that for the most part, that care is going to continue to be needed for patients next year. So that's a kind of first call on the managed underspend that the CCG and commissioning sector has delivered this year. It will be for NHS Improvement and the Department of Health to determine what their aggregate position looks like, but that obviously also has an impact on the available funding. So sort of item number 1 is making sure that we've got this year's care properly funded going into next year. Item 2 is that despite all the great progress actually that's been made on reducing A&E attendances, reducing the pressures in the emergency care system that are documented in the paper, nevertheless, first and foremost, people look to the NHS to provide safe and responsive urgent and emergency care services. So we've got to make sure those are funded properly going into next year. Thirdly, and this is a judgment that this board needs to make, but our recommendation is that we need to protect the planned investment that we've got in mental health services, cancer and primary care services going into next year. The level of unmet need in mental health is now well understood, The practical action plan that we have to implement the Mental Health Task Force, I think, is now getting traction, and we think that delivering on those commitments around the National Mental Health Investment Standard and those targeted service expansions should not be something that gives next year. Similarly, in cancer care, primary care, the pressures on GPs are well understood, and given that primary care is the service foundation of the NHS as a whole, and also, frankly, helps moderate the demand which is flowing into the hospital sector, we think it wouldn't make sense to go backwards on the commitments for improvement that have been made there. So having identified those three considerations, that then kind of moves us on to the fourth, which is the judgment calls that will have to be made about what amongst the other competing priorities can realistically be delivered. And our working principle is that we should try and be as stretching but practical about what that would look like, so as not to set unfair or unattainable goals for frontline staff who, as Matthew said, are already working under very considerable pressure. And underpinning all of this are obviously the welcome announcement that the Chancellor made around funding NHS pay for nurses and other members of staff in the Agenda for Change group. So that's not a call on the additional funding for the NHS. That needs to be considered alongside other pay matters going into next year as well. So those are sort of five principles, considerations that we think are relevant for the discussion with our partners. In process terms, Malcolm, we have until March 31st, obviously, to get this combination of judgments right. The Department of Health will be publicly consulting on their proposed mandate for the NHS for next year. We'll be working with them closely on that. This board will have a chance to have a public update at our meeting on the 8th of February, and then on March 29th, we will need to approve our operating plan for next year, as we are required to do by statute.
Great, thank you very much, Simon. Let me open it up, please, for discussion around the board table. Michelle.
Thank you. Simon, could you talk us through how we intend to involve the public and patients in some of these important discussions over the forthcoming months?
Yes, I think there are sort of several aspects to that. The first is, of course, that we have already engaged many patients groups in formulating the priorities that we set out in our Next Steps plan that we agreed in March, and that was actually a 2-year set of priorities, and mental health and cancer and primary care were signalled there. Secondly, we work closely with, and want to do so over this period, with Health Watch, who have particular statutory responsibilities as well. And thirdly, we will be doing detailed engagement with individual patients groups and with the public, particularly reflected then in the formal public consultation that the Department of Health will undertake, given that ultimately it has to make these judgments about what goes into the mandate.
Thank you.
Yes, David.
Simon, I think it's implicit in what you've said, but I wonder if it needs to be explicit, which is, whilst we have made considerable progress on productivity, you only have to talk to frontline staff to know that there are material opportunities to continue that sort of that focus. And therefore, it seems to me that if you look at the work that's going on in ACS's accountable care systems, in the integration of a fragmented system, that there are quite quick improvements that can be made. And then if you look at the sort of the overhead of what we do, what other people do, that there are plenty of opportunities to continue to drive further efficiency through deployment of technology, removing people looking at each other's homework, which goes on a bit, etc., etc. And therefore, I think one of our considerations must be that we are relentless in our pursuit of efficiency, that every pound that we spend is questioned if it's not spent in patients' care and in supporting our frontline staff. And therefore I'd encourage us to be aggressive in the way that we go after some of that opportunity and to seek to accelerate. So how can we get more ACSs in place? How can we take the Vanguard learning and get that shared? How can we remove variation that if you talk to NHS Improvement they see that we see? And I just would encourage us to be ambitious in our planning, because that is money that could be spent on patients.
Exactly. So I think, as Matthew said, you're drawing out, David, the points that are laid out in summary form in sort of paragraphs 8, 9 and 10 of the report. We are working with new leadership at NHSI to see how fast we can go on that integration agenda, and we want to make sure that the way in which the extra money that's available next year is deployed accelerates and reinforces the kind of movement that you're describing, rather than going down our kind of current ways of working.
And I think there's part of that, Simon, that maybe, if I may, is about engaging also with some of the ACS areas who are the next wave, and saying, what can we do to get you working to that structure more quick, or that structure, sorry, that approach more quickly? What barriers can we remove? How can we make it? How can we redistribute our own capabilities to help that happen more quickly? And I just think there's when times are tough, they've always been tough. When I've been 4 years here, they've always been tough. They're really tough. We owe it to our patients and to our people to up our activity to make those things happen more quickly, and to make sure we spend our money wisely. And I think we'll keep. I think this board will keep pushing you and the team to make sure that happens.
Well, and of course, the very next item we're going to discuss is practical action that we're taking around prescribing costs that is opportunity that will free up money for redeployment and patient care.
Moira?
David's made much of the point I was going to make, but it's particularly about relationships with social care, given the very difficult situation we're in, and the even more difficult situation that they are in. The tendency I've always found is that people want to kind of look inwardly rather than outwardly, and in collaboration. So it's reinforcing the point that David's made, that we must ensure that whatever we do, we enable people to continue locally to try to work together over these very significant challenges.
Agreed.
Wendy?
Yeah, we spend a lot of time as a board talking about finances, but we also spend a lot of time at the board talking about our people and how stretched they are and how appreciative we are of the efforts that they're putting in right now. I was really encouraged acknowledging that. I think the points you made, Matthew, about how much the nurses, doctors, and other staff are doing, and how stretched they are now. As we think about the trade-offs we're going to have to make, how will we think about frontline staff and the further implication of what we're asking or not asking them to do?
Yeah, I think that's absolutely the core. If we are going to make another step forward in the NHS, we need to do it with the efforts and the thoughts of our staff in understanding how to make improvements, as well as just being part of the delivery of that. And I mean, I think of it in terms of kind of three buckets. There's an element which is, do we deliver care in the most effective way? And from the top, NHSI, through many of their actions and through their Getting It Right First Time programme, are trying to drive that. But there is a great deal of understanding within the service itself of ways in which services could be improved if we just listen to people on the front line. And I think that is a local leadership challenge, to be talking to staff about the changes that we need to make on data to make it easier for our clinical staff to do the right thing quickly, and not find that excessive amounts of their time are caught up in non-productive activities because we get in our own way locally. So that's really about local leadership and working with teams to work out how to do to get to the end, the point you're trying to get to better. Then there's the element where we get in our own way, the structural stuff, where we incentivise the wrong parts of working. And you talk to doctors and nurses, and they say, well, we ought to do it this way, but the way the money flows means we do it that way. And what we're trying to do through STPs and through our ACS model is to say, well, let's just lift that out of the way. Now tell us how it ought to be and where the money should land in order to optimise it for patients and how to get the best experience for patients. And that is, again, if you talk to doctors and nurses and midwives and allied professionals across the NHS, they have 100 ways in which, if we could get ourselves out of our own way, we could make it better. And then I think the third part of this is the grand challenge of what does the future look like? What is the role of technology? What is the role of helping people support themselves? How does information technology become part of this? And again, if we do that without our staff talking through what is it that they do and what is it that people need a face-to-face contact with versus people have a face-to-face contact because it's the only way to get the advice that they need, and there are other ways of doing it. Again, there are changes we can make. But if we try and make this against the grain of the NHS culture and NHS clinical staff understanding what works, we won't make the leap that we need to make. So it needs to be really in partnership.
Okay, thank you, Victor.
Three quick points. The first is that, of course, this board has put additional focus on patient and public engagement through the task force that myself and Michelle are chairing. I think that's going to be increasingly important in that regard. I just wanted to mention that, just to ensure that people understood that the board were on it. My second point really is about the mental health commitment that we've made, and I just want to give Simon an opportunity to reiterate and underline that commitment, because this is a tough settlement, and history and experience tells us that mental health is one of those areas that's suffered in the past, and I want to ensure that investment and the standard that we've established around that investment is continued to be pushed. And my third point really is simply this: while I agree with the points that David and others have made about looking out and not up and ensuring that, how do we ensure that in this tough environment that we keep our eye on the inverse care law, i.e. we ensure that those people in need of health and social care the most get it? I think that's one of the principles that we should adhere to in our relationships with other bodies and with the public.
Joanne and John.
Up and down the NHS, we hear that people are frustrated by what they sometimes see as misalignment and duplication amongst the organisations that oversee, direct and regulate them. So I think it was very helpful to hear Matthew talk about seeking to move towards integration as closely as possible within the legislation. So I wanted to endorse that, and I wanted to ask Matthew whether he wanted to say anything more about how we might make that happen up and down the system.
How we move towards the tighter integration. Firstly, I think it is about us creating a culture that that's the expectation. That we are expecting across the country people will be focusing on the health of the population and the one NHS, the how does that wrap around to support people, rather than, as we can sometimes do, tend to focus on silos of our institutions. And so when we get into a room and we say, let's park our institution on one side and think about there is an amount of money to provide care to the people of this city, what should we do as the best? What is the right thing to do? You get a different set of answers to if you try and solve the different pieces individually. So part of this is a message that that's what our expectation is, and then part of it is what are we going to do that every time we inspect, every time we regulate, every time we manage, every time we performance manage, we don't re-separate people back into their silos by looking at them individually. And that requires all of the bodies, be they national, regional or local, that have some sort of oversight responsibility, to be carrying the same culture with them as well. And it's very tough when you're asking the NHS to do one thing and then driving them to do something quite different.
And if I may, Matthew, that's why, and building, I think, on what Joanne was suggesting, that if we need to do it well, but we also need to do it quickly, because that will free up the capacity and the capability, not just financial, but actually more importantly in terms of bandwidth and in terms of energy, to be able to integrate services for patients. And therefore, I think I would observe that the risk of getting things wrong in the NHS when it thinks about its administration often outweighs the risk of not moving quickly enough. And I think in this circumstance we should perhaps reverse that a little bit and put more focus on speed at getting progress done rapidly, and take a bit more risk, as our people are very sensible and they can manage those risks. So I would just put a real plea for acceleration, pace, and taking the barriers away that are stopping local systems that you rightly describe from delivering for patients.
Like millions of others, I've experienced at first hand the impact of mental health on families, and so I want to just comment on that. But also, it's 27 years since I became a consultant. It ends today, actually, when I become a chairman tomorrow. As a hospital specialist, I'd just like to say it's enlightened self-interest to put resources into primary care and mental health, because there's endless experience of if that fails, then it's the specialist hospitals that pick up the tab. So in fact, we have to support that. It just makes absolute common sense.
Yeah. No. I was going to go where John has gone, actually, and I'm pleased Simon said we were going to do our best to maintain momentum on cancer, mental health and primary care. But I was also going to say it's really, really important that we keep up the momentum in our specialised services too. We've done a huge amount to improve access to drugs, quality of service and improvement of outcomes. And it would be a huge shame if we lost momentum around specialist services in the next 24 months. So I would very much hope you would consider putting specialised services really at front and centre of the conversations that we're going to have. Special pleading, I know.
Right, we'll take on board the special pleading. On the basis that there are no further observations, could I just sum up along the following lines? I'm sorry.
There was just one
Victor, please.
In relation to David's point, which is the question really about this pace that we're going to have to keep up, really. I think the key is about how we learn short and think long. So I was wondering about how we are going to learn from what we're doing, and how we're going to put that learning into place as we push forward. Because I don't think it's just about going faster, it's about actually learning from what we've done and putting that learning into practice.
But clear that leadership and contact scores, as you know, you can only do it by engaging, and therefore I suggest that the best way of both moving quickly and learning is by our leaders being present with their people and working and engaging them.
No, I'm not arguing with you. I'm just about have we got the resource by which we can learn and push things forward. That's my point.
I just want to say I think we might be in danger of sounding like encouraging our colleagues to do absolutely everything we're doing, even better than they're doing it at the moment, without recognising that there actually have to be some things that we stop doing. And I do think that that's an important discussion to have with the public, so that they understand that it can't all be done. We obviously have ambitions to do it as well and as quickly as we possibly can, but it is important that there are going to be some very difficult choices for the NHS.
Right, I think that's a very good note on which to conclude. I think, first of all, the board understands that the money is fixed, but that we start from a position in which there are significant deficits both on the trust side and on the CCG side. We have to ensure that we apply additional income to resolving those issues. We can't allow those positions to deteriorate over the coming year. Secondly, although the money's fixed, the things which need to be secured from it are not necessarily fixed. There are additional potential costs which are outside our control, and social care, I think, is an element that we should think about. Pharmaceutical costs are another element, and we'll come back in the next item to consider what we might be able to do there. I think, secondly, we've had a very good discussion about how further efficiencies can be driven through the system, and I take very strongly your point, David, about how we can accelerate and actually use the tightness of the settlement as a catalyst for change and also for energising the things that people know can be done and can bring about improvements not only for patients but also for the staff, but moderated by Maura's point, which is actually we should not set out blindly imagining that our staff can do everything. And I think that's a very important thing. So that brings us to this issue that there are going to have to be tough decisions and trade-offs. I think it's very interesting, if you look at the Commonwealth Fund review of health systems around the world, this is a system that comes out extremely well on every measure except one. In particular, it comes out very well on access to health services. It doesn't come out well on outcomes. And to me, that reinforces I think, agreement around the table about the sheer importance of mental health and cancer and the other horizontal exercises that we're pursuing. So I think, finally, we need to, with our words of advice ringing in their ears, encourage Simon and our executive team to carry out the most rigorous programme over the coming weeks and months, to engage in a public consultation process and to build upon what Simon was mentioning in his outline, to try to ensure that when those tough choices are made, they do accurately and properly and fairly respect the needs of the patients who we serve and the wider population. We need to build into that Victor's constant reminder of the inverse care law and how easy it is to overlook the needs of those who have greatest difficulty in accessing the services. So what we would like, Simon, is as we come through to our meeting on the 8th of February, we'll have a further public update which will absorb the discussion around the table today. And throughout this process, we will be working in the closest manner possible with NHS Improvement, because for them the trust deficit is a very important item, but of course also very closely with the Secretary of State and with the Department of Health. We have to find an accommodation of all of these conflicts, these issues, these difficult areas in order to ensure that when we enter the financial year 2018-19, we're confident of our ability to deliver with the resources that we've got and with the system that we have the privilege to lead on the board of NHS England. That will lead us then through to our meeting on the 29th of March, when we have to agree our own NHS priorities in the context of the mandate, and we'll agree our operating plan for 2018-19. Now, is there any aspect of the summary that I've missed out? No, I haven't. Right, okay. Whilst things look okay, we'll press ahead.
I'll just point out it has started snowing in the meantime.
In the Greek. Right. Thank you very much. Right, well look, what we're going to do now is move on to item 5 on the agenda, which relates to items which should not be routinely prescribed in primary care, finding of the consultation and next steps. And with the conversation that we've just had, setting the backcloth to the decisions that the board is now being asked to make. I would remind the board that this is a process that we initiated at an earlier meeting this year, and today we're reporting, or having a report, on the outcome of consultation. I'm going to ask Bruce Keogh, please, to introduce the item.
Thank you, Chairman. May I start by offering an utterly insincere apology for 100 pages of papers to board members, which I will try and summarise relatively concisely. But this is an important consideration, and if there's a measure, in a sense, of how busy primary care is, it's reflected in the fact that there are 1.1 billion prescriptions a year issued out of primary care at a cost of over £9 billion a year to the NHS. And all around the NHS, there are endeavours to deal with efficiency, cost effectiveness and value for both taxpayers and patients. And that, in essence, is the background to this paper. There are two questions, in my view, for the board. The first is, could the board consider and approve the guidance that we've previously seen and has now been refined, and I'll come back to that. And the second is, would the board consider approving progression to work on how we might review some exchange between prescription medicines and over-the-counter medicines. Now, You will recall that NHS clinical commissioners had drawn up a list of items that they thought should not be routinely prescribed in primary care for a mixture of clinical, financial, and safety reasons. And they approached us to ask us if we could help them to produce some guidance to A, reduce duplication across 200 CCGs and to reduce unwarranted variation in the prescription of these items. Simply by reducing routine prescribing. Now, I need to be absolutely clear that the key is in the words routine prescribing. This is not a ban on medications, because in medicine it is dangerous to ever say never. And we need to also understand that when GPs are confronted with individuals, they have to take a compassionate view which applies both to the individual's clinical circumstances and social circumstances. So this guidance is about the promotion of judicious prescribing throughout the NHS. Detailed work has been undertaken, and I think a great deal of credit needs to go to Bruce Warner, the Deputy Chief Pharmaceutical Officer, who's worked with NHS clinical commissioners, other pharmacists and stakeholders to produce the guidance. It was presented, as the chairman said, to the board in early July as draft guidance, and we approved it to go out to consultation. Within that consultation, we also included some questions about limiting the prescribing of over-the-counter medicines. That consultation was conducted between the 21st of July and the 21st of October. We received over 5,500 responses online, almost 200 responses by mail. We had 8 stakeholder webinars, 2 face-to-face public events, and 3 stakeholder meetings, which included industry, pain management, and mental health groups, to name some. So, as a consequence of that consultation, the guidance has remained largely unchanged, but there have been some pretty important refinements, particularly relating, and I won't go through all of them, but I'll give you a flavour, L-thyroxine, otherwise known as T3, which is an expensive version of thyroxine, when many people will do better with something called T4, which is a cheaper version of thyroxine. And it has been recommended that T3 should only be prescribed on the advice of an endocrinologist. We've made some changes to the recommendation around lidocaine plasters, which I'll come to in a moment, and immediate release fentanyl. Now, immediate release fentanyl is a very powerful painkiller, and we're being absolutely clear that whilst this should not be routinely prescribed, it should not be withheld in palliative care. Coproximol would be another example. Coproximol is a painkiller where safety alerts started to emerge in the mid-1980s, and in 2007 it was fully withdrawn from the UK, but is still being prescribed. As part of our review of the consultation process, we asked the Specialist Pharmacy Service to commission an independent review, in particular of 2 things, of lidocaine plasters, and they came to the view that lidocaine plasters had value in post-herpetic neuralgia. The second area you asked them to look at was homeopathy, where they came to the view that there was no robust evidence to support the routine prescribing of homeopathic remedies on the NHS. You have the guidance in front of you. You've seen it before, with the exception of these few refinements. I'm now asking the board approval for that guidance for the NHS. On a separate topic, we've also identified 26 minor conditions where over-the-counter medicines are perfectly effective, and in the consultation, substitution of prescription medicines for over-the-counter medicines has been broadly supportive. So my next question to the board is, would the board be content with us proceeding with some work to look at how we might make better value of this by the use of over-the-counter medicines and to start some further work and go out to consultation. Thank you, Chairman.
Well, thank you, Bruce. None of the material is unfamiliar to the board by virtue of having already come before us earlier this year. But I think what is noteworthy is the extent to which public consultation has brought about some changes in the advice. So let me invite colleagues to ask any questions of Bruce or to make further comments on the paper. David.
Bruce, I think generally speaking fine. There's just one assurance I'd like, which is I was conscious that in the response to the consultation, out of 2,600 patients who responded, over 2,000 were female. And therefore I just wanted to get your absolute assurance that there was nothing in this that impacted or created any inequality or any bias.
No, in the papers you will see that we've done an equality assessment. I don't think that there's anything that would give me cause for concern over that particular observation.
Thank you. Moira?
I'm fully supportive of the recommendations. They seem very sensible and have been treated very thoroughly. I just would like to ask if in the further consultation on over-the-counter remedies that care homes are considered are definitely consulted with, because obviously there's a risk of a transfer of costs directly to them from these changes.
Thank you. That's a very helpful comment, and of course we'll take that into account.
Can I just ask one? Sorry.
Malcolm, I think it's great to be able to welcome this. It's nice to see that after such a diligent and thorough piece of work, we're able to see recommendations coming forward which advance both economy and safety and patient quality. So I think that's great. The observation I would make, sort of on behalf of colleagues in the NHS, is that the final guidance document itself, whilst very thorough, is a combination of sort of telling the story of how we've got to where we've got to, as well as what the final answer is. And I would like to ask whether we might consider writing a companion document to the guidance, which will be succinct and brief and will be and make it easier for around the country people to implement this. Because otherwise, my expectation would be that multiple people around the country will be picking up this document and trying to translate it into, well, what are we going to do in our area? And I think we could help with that and reduce workload.
Of course we can do that.
Right, well, that was ready acceptance. Victor, did you want to come in?
There was just a question I had in my mind about, while I agree with the principle sensible, how are we going to monitor for unintended consequences? Because there are some, we discussed this, there are some gaps in data, which may mean that I refer to the inverse care law. So I'm just wondering whether that's something that we have in mind.
I think we need to take that away and think about it, Victor. Monitoring for unintended consequences is always difficult because you can't monitor for something until it starts to emerge, really. So we will take that away and think about it.
Right, well, subject to those two assurances, one about unintended consequences and two about maybe a simplified version of the guidance, may I invite the board to approve the final recommendations in relation to the 18 items considered to be relatively ineffective, unnecessary, inappropriate or unsafe for routine prescription. Fine, that's agreed. And then secondly, on over-the-counter medicines, to note the findings of the public consultation and note that we're going to go into further consultation by engaging with patient groups ahead of another formal public consultation. Are we content to endorse that? Okay. Thank you very much. Thank you very much, Bruce. And would you please, we can couple that with thanks to your team for having undertaken this extensive work. Right. I would like now then, please, to move on to item 6 on the agenda, which is congenital heart disease services for adults and children. I'm going to invite John Stewart, Director of Specialised Commissioning, and Huon Gray, who is our National Clinical Director, to join us at the table. Can I just repeat to the board what I said in my opening comments, which is that I'm going to invite Sir Bruce Keogh to introduce the paper, but because of the role that he will have quite shortly as chair of Birmingham Children and Women's Hospital, he will then leave the room, as will Sir John Byrne, who shortly will take up his chairmanship of Newcastle upon Tyne Trust. So, Bruce, on that basis, may we invite you to give us an overview, please?
Thank you very much, Chairman. And can I also be clear with the board that since I was appointed to a position at the Birmingham Women's and Children's Hospital, that I've recused myself from all discussions related to this. My background, as everybody on the board will know, is as an adult cardiac surgeon, and in that capacity, in a past life, I've held a variety of national and international leadership roles. Perhaps more relevantly, I've been a clinical director in both Birmingham and at the Heart Hospital, which I think are the two biggest adult congenital heart surgery units in the country, and I noticed one of my previous colleagues in the audience. I've also been involved in the measurement of outcomes in cardiac surgery over many years in UK and Ireland, the United States, Europe, Japan, and China. And the measurement of outcomes is sort of important to this issue. One thing that I would like to say, although I understand some aspects of congenital heart surgery, it is a very technically demanding specialty. I couldn't do it technically or emotionally. It is complex. It involves operating in a highly complex environment with a great deal of technical skill and the ability to see in 3 dimensions on hearts which might be the size of a walnut. This is not easy stuff. And you have to do that, I think, in the face of very high hopes and expectations from families and parents who are deeply worried about the well-being of one of their kids. So the starting position that we really need to understand is this is the cutting edge of surgery, ethics, emotions, and technical endeavor. So against this background, in the 1990s, there were problems with children's heart surgery in Bristol, which resulted in a public inquiry which was led by Sir Ian Kennedy, which reported in July 2001, so about 17 years ago. There were 196 very pragmatic and sensible recommendations in that review, but broadly speaking, the last 6 of them refer to the need for national standards, the need for a minimum number of procedures, the need for this kind of surgery to be conducted in a pediatric environment, and the need for external monitoring of results. And there was a thread right throughout this that there was a need to rationalize service delivery to meet those standards. And I put it to you that in many respects, that's what we're here to discuss today. This was seen in the cardiac surgical community, this report, as devastating. It required a lot of surgeons around the country to think about how services should be delivered, and I think it galvanized the cardiac surgical community in certain areas, particularly in the measurement of surgical outcomes. And I'm pleased to say that we have a central cardiac audit database and a congenital component of that, which is, if not the best in the world, certainly one of the best in the world. And one thing that we do know from that is that outcomes for congenital heart surgery in this country are good. And we need to be clear about that. Since the review in Bristol, there was another review conducted by the late Jim Munro, a very respected pediatric cardiac surgeon in Southampton. that really endorsed many of the findings that were made in the Bristol inquiry, but emphasized the need for a redesign of our services and the way that we provided them. In 2006, when I was involved with the Society of Cardiothoracic Surgeons, I think I was president at the time, the service started to become very fragile again. There were a number of single-handed surgeons practicing in units. There were people feeling under enormous stress. And I was asked to write, as president of the society, to the government to ask whether they would conduct a review once again, because the specialty was frightened that we were heading into the sort of territory that would lead to another Bristol. So in February 2007, I wrote to the Department of Health asking for a review of congenital heart surgery in this country. In November that year, I was appointed as medical director of the NHS, and there was a need to take forward the letter that I had written earlier that year. So in 2008, this was discussed at the NHS Management Board, and that resulted in the institution of a review of congenital heart services, which was called the Safe and Sustainable Review, which was led by a joint committee of PCTs. And they made a series of recommendations about units that should remain open or closed, which were seen as contentious. During the course of that particular review, there were 2 judicial reviews, and finally the Independent Reconfiguration Review Panel took a view that there were some deficiencies in the way that that review had been conducted. The end result was that the Secretary of State couldn't support it, but at that time NHS England was forming. This was around about 2013, and he asked the newly formed NHS Commissioning Board, otherwise known as NHS England, to re-look at congenital heart surgery, or congenital heart services. And so a new review was instituted. And that review, I think, is distinguished by the fact that it was based on, or has been based on, clinical standards to meet the intent of the original review. Now let me be clear. I've said to you that results of pediatric heart surgery in this country are good, but that they had become fragile. So the intent of the original Safe and Sustainable Review was A, to stabilize services, B, to future-proof them in the face of advancing technology, rising patient, or rather family and public expectations, and the advent of more adventurous surgery on younger and younger children, even venturing into in utero surgery. And the final thing was to create an ambition within the NHS that we could offer the best congenital heart services in the world. So those were the 3 intents of the original review. During the course of the Safe and Sustainable Review, I think things became quite tricky in some of the discussions, and I fear that the original intent got lost in some of the debate. So my plea to the board today is that we're kind of reaching crunch time. This has been going on since 2001. We need a solution, and we need to be clear that this solution is not about the past. It's not even about the present. It's about future-proofing these services for babies who have not yet been born. And the uncertainty that has surrounded the last 17 years or so has been highly counterproductive for people working in this particular specialty. It's pitted unit against unit, clinician against clinician, parent against parent. And if prolonged, I fear that the very intent, the original intent, noble intent of the initial review will be completely undermined, and the ambition for our NHS will be lost. And the only losers, in my view, will be unborn babies. And so that, I think, is the way I would like to frame the debate for the board, Chairman.
Bruce, thank you very much. That's a very powerful framing for the board. I think now if you and John would like to stand down. Before I invite John Stewart to speak to the details on the paper, I just need to check one thing, that all members of the board have had all the papers. So there's quite a bundle in here. Everybody's had the opportunity to read them all, because we are about to take some quite serious decisions, and Bruce has just emphasised to us the sheer gravity of what is at stake here. And so let's proceed on that basis. Thank you, John. Thank you, Bruce.
Thank you, Malcolm. So good morning. I'm John Stewart, Acting Director of Specialised Commissioning, and I have been the SRO for the Congenital Heart Disease Review. I'm joined by my colleague, Professor Ewan Gray, who's the National Clinical Director for Heart Disease. So I know that board members have read and studied all the papers carefully, so I will try and be reasonably brief in providing an overview of the recommendations before the board. But can I begin by saying that services for CHD in England are very good, and survival after surgery is as good, if not better, than anywhere in the world. That said, the origins of this review, which Bruce reminded us about, which stem from the publication back in 2001 of the public inquiry into concerns about the care of children receiving complex cardiac surgery at Bristol Royal Infirmary, remind us of the importance of not being complacent. We believe there is scope to secure further improvements and, crucially, the opportunity to make some further adjustments that will ensure services can respond to future clinical, technological and scientific advances, and in doing so maintain their world-leading status. We have adopted a standards-based approach to this review. That is what patients, their families and clinicians asked us to do, and so working with them, the standards for both adult and paediatric CHD services were developed and describe what excellent care looks like. These standards were approved by this board back in 2015, and they describe 3 levels of CHD service provision. Level 1 specialist surgical and interventional CHD centres, which manage all patients with highly complex CHD and provide the most highly specialised diagnostics and care, including all surgery and interventional cardiology. Level 2 specialist medical cardiology centres, which provide the same level of specialist medical care as Level 1 centres, but not surgery or interventional cardiology, with a few exceptions. And Level 3 local cardiology services, which are accredited services in local hospitals run by general paediatricians and cardiologists. Importantly, patients told us that the standards only mattered, though, if we ensured they were met. Otherwise, they were a waste of time. We therefore set out proposals to implement the standards and asked for views in a formal public consultation that ran between February and July this year. The vast majority of those standards can be met at every hospital currently providing Level 1 services with the right focus, attention and in some cases extra investment. However, there are 2 very important areas covered by the standards that have proved more challenging for certain hospitals to meet. These are the standards that relate to surgical activity, which require by 2021 Level 1 centres to have a team of 4 surgeons, each undertaking a minimum of 125 procedures a year. And then the paediatric co-location standards, which require Level 1 centres providing paediatric cardiac care to have a range of other paediatric specialties on the same site from April 2019. Both these standards are really important, and I'm actually going to just ask Professor Gray to provide a little bit more detail about the significance of them.
Thank you very much. We're just taking the the surgical numbers standard. As Sir Bruce has already pointed out in his introduction, this is very complex and varied surgery, and many operations are not alike. Surgeons require adequate experience for each surgeon within a team, and the standard is, as is in the board papers, 125 operations per surgeon, which roughly equates to about 3 procedures per week. Now this follows wide consultation amongst patients, patient interest groups, professionals, and is a number that's been supported by surgeons themselves. These are not figures that we've just derived. They're supported by the Specialist Society of Cardiothoracic Surgeons, Royal College of Surgeons, and the British Congenital Cardiac Association, whose recent president, actually, David Anderson, is quoted as saying that we must set a minimum in order that a surgeon has an acceptable level of skill refined and maintained through regular practice. So I think the number per surgeon is important, and it has been derived with a considerable amount of professional input. Just talking about the other issue of co-location, that is the location on the same site of other children's services alongside children's congenital heart disease services. And that has been that has arisen because children with congenital heart disease often have other conditions that require specialist input. And this specialist input needs to be available on the same site for a number of reasons, partly to avoid travel of the patient or the specialist, also to have the speed of availability of expert opinion in the situation of an emergency, but also importantly and sometimes overlooked, the ease of interaction between congenital cardiac surgical teams and other specialist teams in the decision making and the planning of care for patients. And care for children needs to be in a child appropriate setting. The clinical panel felt that this was an extremely important standard to be achieved, and the Royal College of Paediatrics and Child Health support this with a quote that is as follows: "Isolated children's services are unacceptable. Specialist children's cardiac services must be delivered within a hospital providing a broad range of other specialist children's services." So again, this standard has been derived with a lot of professional input.
Thank you. So having assessed all existing level providers against the standards, 4 trusts were identified as being unlikely to meet the standards in the required timeframes, and were therefore the focus of our proposals for change and our formal consultation. These trusts were Central Manchester NHS Foundation Trust, now known as Manchester University Hospitals NHS Foundation Trust, University Hospitals of Leicester NHS Trust, the Royal Brompton and Harefield NHS Foundation Trust, and Newcastle upon Tyne Hospitals NHS Foundation Trust. We received 7,673 online consultation responses and a further 78 other written responses, which I think demonstrates the strength of feeling around these services. A detailed independent analysis of these responses is included in Annex A and has informed the recommendations being presented to the board today, which I will now take in turn. So starting with the North West. In the North West, Level 1 specialist inpatient services for people with CHD have to date been divided between 2 cities. Liverpool, where children received their care at Alderhay Children's Hospital, and Manchester, where adults received their care at Manchester Royal Infirmary. Running the service in this way, though, inevitably meant compromise, because it meant the adult service depending on a single surgeon. He could not be there all the time, and the distance between the cities was such that cover could not be provided from Liverpool. There also wasn't enough surgical work to allow him to meet minimum volume expectations, just 92 operations in 2016-17. As such, NHS England's proposal was to bring Level 1 services for adults and children together in Liverpool, with Alderhay continuing to provide the children's service, who were already providing 415 procedures in 2015-16, and Liverpool Heart and Chest Hospital being commissioned to provide the adult service as part of a single surgical team working with Alderhay. As a consequence, the Level 1 adult service would be decommissioned at Manchester, but it was envisaged that they would continue to provide the full range of Level 2 services as part of a North West CHD network. The recommendation before the board and set out at the end of paragraph 28 is that the original proposal on which we consulted should be taken forward. However, this should be conditional on the Liverpool Trust providing robust and adequate support for the full range of Level 2 services in Manchester as part of the North West CHD network. Under these network arrangements, we would expect Manchester University Hospitals NHS Foundation Trust to continue to play a leading role in providing maternity care for women with CHD, including the development of care pathways and the coordination of multidisciplinary discussions of maternity care. We would expect that care for women with such complex needs would be discussed at the North West CHD Network Multidisciplinary Team meeting to determine the best place for delivery. A more detailed implementation schedule is set out in Appendix 1 to the paper. Moving on now to University of Hospitals of Leicester NHS Foundation Trust. The original consultation proposal here was to decommission Leicester as a Level 1 centre. This was principally based on the assessment that they did not at that time have a credible plan to either meet the paediatric co-location standards or the surgical activity standards. However, since then, the Trust has come back with a convincing plan for achieving the co-location standards. Furthermore, they have submitted a detailed growth plan, included at Annex E in your bundle of papers, setting out how they will meet the surgical activity standards in full. To underpin this plan, the Trust has been working hard to build relationships and establish networks with referring hospitals across the East Midlands region, and at Annex D there is evidence of this in the form of letters from hospitals across the patch indicating the likely referral numbers into Leicester if they were to continue to be commissioned as a Level 1 centre. In light of this, the recommendation before the board and set out at the end of paragraph 33 of the paper is that we should continue to commission Level 1 services from Leicester, but that this should be conditional on the Trust achieving full compliance with the standards within the required timeframes as described in its own plan to do so. Again, a more detailed implementation schedule with key performance indicators on progress is set out at Appendix 1. In terms of the Royal Brompton and Harefield NHS Foundation Trust, the original consultation proposal was to decommission the Royal Brompton as a Level 1 centre. The principal reason for this was that there was no plan for achieving the paediatric co-location standard. However, since then, and in response to this prompt, as part of their response to the consultation, the Trust has presented a joint proposal to collaborate with another of the hospitals in London, Guy's and St Thomas's, part of the King's Health Partnership. This proposal, which is set out in more detail at Annex G of your papers, would see the CHD services offered by the two hospitals brought together. Cardiac services for children would be provided from the new buildings to be developed as part of the Evelina Children's Hospital, with the adult service provided from a newly created Heart and Lung Centre, with both developments forming part of the St Thomas's Westminster Bridge campus. This is undoubtedly an ambitious proposal which would not only achieve full compliance with the CHD standards, but would also have the benefit of keeping other key services, including paediatric respiratory services, as well as research teams together. As such, the recommendation before the board and set out at the end of paragraph 38 is that the board should support the further development of this plan, which could include other potential partners, and continue to commission Level 1 services from the Brompton in the meantime. The continued commissioning would be conditional on firm progress being made in developing the new proposal and taking it through the usual business case approvals process. Again, a more detailed implementation schedule is set out at Appendix 1. Moving finally on to Newcastle upon Tyne NHS Foundation Trust. So in terms of the original assessment against the standards, Newcastle was assessed as not meeting the co-location standard, nor likely to meet the surgical activity standards in the timescales required. However, it was recognised that decommissioning the CHD service would make the intertwined advanced heart failure and heart transplant service for children and adults with CHD immediately unviable. This is one of only 2 centres in the country providing this service. Therefore, the board agreed that its consultation proposal should be to continue to commission Level 1 CHD services from Newcastle and allow the Trust more time to meet the standards. The recommendation before the board and set out at the end of paragraph 43 remains consistent with this original proposal. It is recommended that the commissioning of Level 1 services should continue until at least March 2021. However, recognising the importance of the quality and sustainability of both the CHD service and the interdependent advanced heart failure and transplant service, the board is invited to agree that further consideration should be given to the future commissioning of both. This would then inform our commissioning approach from 2020-21 onwards, but until the outcome of that work is known, a derogation against the 2019 co-location standard should be applied. Again, Appendix 1 sets out a more detailed implementation schedule. Finally, the board is asked to confirm the commissioning arrangements for Level 2 services going forward, as set out in paragraphs 45 to 47 of the paper, and to note the further action set out in paragraphs 49 to 52 to support full implementation of the standards, including better information, establishing and funding formal CHD networks, and putting in place a rolling peer review programme. So in conclusion, the recommendations presented to the board today modify NHS England's original consultation proposals. This is because we've listened to the views expressed during consultation and have considered new proposals and information that have emerged along the way. If accepted by the board, their implementation will further support us in moving towards full national compliance with the standards, meaning that every operation or cardiology intervention for CHD patients will be carried out by specialist doctors with a volume of practice sufficient to develop and maintain their skills. All children with heart disease will receive their inpatient care in a holistic, child-friendly environment. Daily interaction between clinical teams will be facilitated. Resilience will be enhanced through larger Level 1 centres with bigger teams. Care will be delivered as close to home as possible through network specialist Level 2 centres, Level 3 centres and outreach clinics, all coordinated by the network team. And finally, occasional and isolated practice will no longer be permitted, so low-volume surgery or interventional cardiology in institutions without sufficient specialist CHD expertise will cease. Thank you.
Thank you very much, John. That's a very good and succinct summary of what has been an enormous amount of work. So I think that the framework through which the board would wish to look at this is, first of all, how far the proposals that we endorsed at the last meeting in relation to this have been taken through the process, and the extent to which they've changed still represents the consistency that we wish to see in application. I think, secondly, the extent to which, particularly in relation to Leicester and the Royal Brompton and perhaps also to Newcastle, there is sufficient assurance to the board that the continuing commissioning of these services will continue to nonetheless ensure that those very standards of quality that you and Sir Bruce have referred to will continue to be maintained. I think this is of critical importance to the board. And then finally, I will then invite the board to consider whether they're willing to endorse each of the recommendations in turn. So may I, having set that framing, invite the board to address any comments or questions to both John and Huon. David?
I guess a question, I think, Huon, I see from the papers that you've spent some time in the Northwest. And I guess two things. One is confidence that Liverpool Heart and Chest can build the capability required and work effectively in the manner envisaged. And secondly, observations around maternity provision in Manchester and the extent to which you feel there is the appropriate collaboration and support within that network to make it work.
Thank you. With regards to the first aspect of that, Liverpool Heart and Chest Hospital's ability and capacity to respond, I'm confident that they are able to do so. Liverpool Heart and Chest is already a premier adult cardiac surgical centre, so it's not as if they're coming from a completely standing start. Admittedly, there's work to do to develop these adult congenital cardiac surgical services and interventional services, but I'm confident that they have the staff either now or by recruitment that will allow them to achieve that. With regards maternity services, We did spend some time discussing this. I visited the Northwest, and we had what I found at least a very fruitful meeting, of which maternity services was one aspect of the discussion. The care of women who are pregnant and those women who have congenital heart disease it requires appropriate multidisciplinary team management and advice. The vast majority of women, even with congenital cardiac disease, can be managed relatively close to home with appropriate supervision. Very, very few will need to be delivered of their child in a level 1 centre. So those who live within the natural sort of Manchester catchment population, we would expect would continue to have their care there. Manchester Maternity Services has a very good track record, and the network is very much of the mind that they should build on that, and that it should be seen as a network response to delivering the best possible care for all women who are pregnant with congenital heart disease.
Thank you. Noel?
I should preface my question by just noting the intensity of thoughtful scrutiny that's been given by Specialised Commissioning Committee of the Board over these proposals over the last year. So my question really, I think I know the answer to, but I think it's of general interest, which is around the interim arrangement. So given there's huge clinical support for the standards that are being set, as you rightly said, Hugh, and I think many patients and parents will be interested in what is the oversight that is going to be given to the hospitals that are in transition to meet the standards. In some cases over the next 3 years, and what assurance you can give that the way in which we're delivering service in these locations in the interim period to the point where they reach their target standards. What is the oversight that we're going to give to ensure that the services are safe and that the outcomes are improving?
Maybe I could start this and then maybe ask John to respond specifically to the commissioning oversight. Bruce referred to the fact that all congenital cardiac centres in this country have felt very much under scrutiny for many years. And that's not been an easy situation to live with. But over the intervening years, to some degree, this level of scrutiny has driven up standards considerably already. You know, we are in a position where we can talk about good results, good outcomes, good services, which wouldn't always have been the case in the past. So my response would be that some of the scrutiny is going to come locally. Some of the assurance of local services against the standards will be through centres themselves, knowing that they have these nearly 200 standards, having gone a long way already to achieving these standards and continuing to do so in the future. The specific commissioning oversight of the implementation of these standards over time, I'll ask John perhaps if you could comment.
Yeah, so NHS England, as the responsible commissioner for these services, obviously has a critical role to play in both setting out what our expectations are for patients around the achievement of the standards over time. And I mentioned that within the board paper and linked to the decisions, we have set out more detailed implementation schedules that clearly set out what we will be expecting to see from all of these trusts over the coming years towards delivery of the standards in full. But I think we have an additionally very important role then in supporting and working with all of these trusts in actually meeting the standards and helping them to do so. So Hughan has already spent a lot of time in the Northwest working with Manchester and Liverpool to think through the new arrangements. It will be absolutely critical for NHS England to work closely now with the Royal Brompton to support them in developing their alternative proposals, and similarly with Newcastle. So I think we have a kind of dual role of both kind of assurance on behalf of patients, but also actually working very closely with those trusts to achieve the standards.
Thank you. Joanne?
Thank you. The proposals have rightly focused on the technical issues of quality and safety. And what I wanted to ask was, in in the recommendations, have you taken account of the possible impact on patient choice? And is there any risk that in seeking to reach the technical volume requirements, patients are being, if you like, funneled into centres? So how will this impact on patient choice?
Yeah, perhaps I can take that. So I suppose if anything, the decision now to continue to commission services from Leicester means that there is an additional centre from which patients can continue to choose to have their treatment from. I think the thrust of the question, though, is in trying to ensure that all these centres meet the required surgical activity standards. Is there any kind of sense that we are going to try and kind of mandate referral pathways? And the answer to that is absolutely not. We have been clear throughout that patient choice is absolutely paramount in this. And if we take a look at Leicester as a specific example, in the work that they have been doing with trusts across the East Midlands patch, they have been at great pains to point out the importance of respecting patient choice. What they are working with those referring centres to do is make sure that this is available as an additional choice and option for patients. So I think that's absolutely clear. There is no intention to direct or mandate patients to any of these particular centres.
Thank you.
David.
John, clearly Leicester has had considerable uncertainty and now has a plan set out and a set of milestones to work through, and has attracted considerable support from local hospitals to their plans and proposals. I guess we should just seek your assurance that you think the plan that's put forward is credible and also is not going to, if you like, by building volume in one centre, denude other centres and lead to instability sort of elsewhere. Because clearly, once we've made this decision, we need to help and support Leicester to go through what's quite a big sort of build over the next couple of years.
Yes. So the first thing to say is that both NHS England and Leicester are in complete agreement that there is enough activity across the patch in order to meet the surgical activity standards, which is the really key one in question. The challenge really for Leicester is in increasing the number of referrals to that centre. And you will see in that growth plan that has been submitted and included at Annex E to the papers that there are quite considerable letters of support from those referring centres. So a lot of work has happened over the past few months to build and establish stronger and new networked relationships with those trusts. So on that basis, I think the position is looking positive, and I think we absolutely need to want Leicester to succeed in this. When you look at those letters, you also can see the level of predicted volumes they think those referring centres will are able to kind of commit to, although we're not talking really until about 2021. By my calculations, I think we can be reasonably optimistic that there are already strong evidence that 450 referrals look very achievable, and that there is sufficient remaining activity for them to hit the 500 standard. It's probably worth saying that there are some of those hospitals within the East Midlands patch who at this point in time have felt unable to make a kind of firm commitment around what they think will happen in 3-4 years' time, and I think that is perfectly reasonable. In terms of your second point about the impact on other centres, the inevitable consequence of maintaining one centre is that it may have an impact in terms of reducing the numbers in other centres. What we do know, though, is that the kind of main centres that potentially could lose out would be Birmingham and Great Ormond Street. However, we've very carefully looked at those numbers and are confident that actually they will still be able to maintain their required activity numbers.
Wendy?
Yeah, that's a very considered proposal. Thank you. Newcastle, perhaps you could just talk a little bit about that in the approach, because obviously we're shaving our opinions somewhat in the quality standards and things like that in terms of numbers and keeping that program together. Could you just give a little bit more comfort with that?
Yeah, so I wonder if it's helpful if we kind of maybe here on you can begin by explaining the kind of connected nature of actually the CHD service and the heart transplant service, because I think that will help us understand the issues there.
Thank you. Yes. Whilst we will obviously focus on the standards of co-location and numbers of procedures for obvious reasons, there are almost 200 standards, and we would be working with and expecting to see Newcastle delivering against the wide range of standards that define best quality of care. But specifically, with regards to these two crucial standards, Newcastle is somewhat different from other centres, as I'm sure you appreciate, because of the location of congenital cardiac transplantation services. In terms of paediatric cardiac transplantation for congenital heart disease, it's one of two centres, the other centre being Great Ormond Street, and it undertakes the majority of transplantation for adults with congenital heart disease. In addition, it has quite advanced heart failure services, and the clinicians who are involved in these two respective services overlap considerably. So there is a concern that if one were simply to decommission on the basis of, at the moment, on the basis of co-location and surgical numbers, one could destabilise a very important service, which obviously no one would wish to happen. Newcastle has already given plans as to how it would achieve 375 numbers of procedures with 3 surgeons. As John has pointed out, it's proposed that they shouldn't be held to co-location at the moment until some extra work has been done to understand the nature of the heart failure and transplant services alongside congenital services, because transplantation and heart failure services were not part of the remit of this review. So I think the answer is that we do wish Newcastle to achieve the same standards. We're giving a longer time scale and a further period for discussion based on investigation of the heart failure and transplant services.
Yeah, and I just think to add to that, we need to be really clear that the decision we're asking the board to take today is to continue to commission from Newcastle until at the very least 2021. But there is, I think, an important need to look at both these two services combined, which actually really was kind of out of the scope of the national CHD review. So I think a more focused bit of work to try and think about how can we make sure that those patients who need both services can enjoy and meet the standards that we would expect across the board.
Okay, well, thank you very much for that. I think the board would wish, first of all, to commend all of the hard work that's been done. Secondly, to take assurance, both from the comments we've just received, but also the assurance that's set out in the papers as to the deliverability of each of these proposals. I think, thirdly, we've all read the very comprehensive decision-making business case, which gives us assurance about milestones and how this process will be overseen. And I think, finally, also, actually, it really opens our eyes to what commissioning is, as opposed to just a process of entering into contracts, which people sometimes assume as commissioning as a process of completely engaging with the providers of services as to what improvements we wish to see for the benefit of patients, making decisions and then working closely with those providers to ensure that those benefits are delivered. So we're grateful to you for that. Could I then invite the board, first of all, of course, to note the consultation and to be satisfied that the consultation has brought forward proposals which have been taken into account in developing the revised proposals that were before us. Note the reassurances that we've had, and then I think I should, in case of each of these, invite the board's endorsement or otherwise of each of these proposals. First of all, Commissioning Liverpool Heart and Chest Hospital NHS Foundation Trust to provide Level 1 adult CHD services in the North West, with Manchester University Hospitals NHS Foundation Trust providing the full range of Level 2 adult CHD services as an integral part of that network. Are we content to approve that proposal? Thank you. Secondly, continuing to commission University Hospitals of Leicester NHS Trust to provide Level 1 CHD services conditional on achieving full compliance with the standards in line with their own plan to do so and demonstrating convincing evidence of progress along the way. And we will wish to see that convincing evidence in updates to the board as we go over the next couple of years. Thirdly, backing the Royal Brompton and Harefield Foundation Trust's ambitious new outline proposal for achieving full compliance with the standards and continuing to commission Level 1 services from them in the meantime, conditional on demonstrating convincing progress along the way in their relationship with King's Health Partners, which is the proposal that they brought to us. Right, we agree with that. And then continuing to commission Newcastle Hospitals NHS Foundation Trust to provide Level 1 CHD services until at least March 2021, with further consideration to be given by us to the future commissioning of both the Trust's advanced heart failure and transplant services and its Level 1 CHD services. And we're content to endorse that. So the summing up then is the board is content to endorse the proposals that you've brought to us today. We will wish to obviously maintain a close oversight of the pursuit of the various conditions that we are proposing should be imposed. Good. Thank you both. And by the way, may I thank you again, both personally and through your teams, for what's been an immensely complicated and challenging programme. I am personally satisfied that what we have decided today will bring significant benefits along the lines that Bruce Keogh outlined to us at the beginning of the session. So thank you for that. Right. We will be rejoined in a moment by Bruce and by John, but will you forgive me if I press straight on to the item 7 on the agenda, which is the report by the National Guardian for the NHS. Henrietta Hughes is with us. She's coming. Yep. Thank you, Henrietta. Thank you so much for coming to join us this morning. We've had an opportunity to look at your report. I think we're being given physical copies as well as the digitals. Thank you very much. And I'm going to invite Emily Lawson to, and I should explain that Emily is our NHS England Freedom to Speak Up Guardian. Emily, would you please introduce yourselves?
Thank you. My role here is really just to introduce Henrietta, who's going to take us through the covering note on the annual report of the National Guardian's Office. Obviously, the ability of all our colleagues to be able to express themselves and to raise issues through multiple avenues is incredibly important to us, and the freedom to speak up is one way of ensuring that if perhaps the most obvious routes are closed, there are other ways, other places and other people for them to talk to. And Henrietta's going to tell us where we're at with that.
Thank you very much, and it's a really great privilege to present to the board today, and thank you very much for sponsoring my organisation. If I can just take a couple of minutes just to summarise the last year, and then I'd be happy to take questions. So my vision is for the NHS to be the global leader in creating a positive speaking up culture, and this will improve patient safety and staff experience by enhancing leadership, driving continuous improvement and reconnecting the leadership to the front line. I want other sectors of the economy to learn from and incorporate the innovation of the NHS, and for us to learn from their experience. I started as a National Guardian in October last year. I established the governance and staffing of my office and ensured that all trusts and foundation trusts in England have a Freedom to Speak Up Guardian. They're supported through regional networks where Guardians can buddy and mentor, share resources and learn from innovations nationally. Private providers and leadership organisations such as NHS England have also appointed Guardians, and we're actually holding the first arm's length body network event today. The Guardians come from a really wide range of professional backgrounds and seniorities, and while currently they are less representative in terms of diversity than we would like, this is something we're working to address. They work differently from other tribes in the NHS, with an enthusiasm to share and learn across geographical, organisational and professional boundaries, with a common purpose to make speaking up business as usual in the NHS. I recently published a survey of Freedom to Speak Up Guardians, and I've established 10 principles in how the role is best appointed with sufficient diversity in time, access to leadership and effective communication of the role. And if you turn to the centrefold of the written report, then the principles are there on page 16. But we also correlated the Guardians' perceptions with the CQC inspection reports. And on the right-hand side of page 17, there are 3 graphs. In outstanding trusts, the Guardians overwhelmingly agree that speaking up is taken seriously. That's the bar on the left-hand side. That there are no barriers to speaking up, and that managers support staff to speak up. And this is in contrast with the Guardians from inadequate trusts. Nationally, we're also publishing case studies and quarterly data on speaking up. Over 5,500 issues have been raised. In the last quarter, 30% of these were on patient safety issues, and over 50% related to bullying and harassment. I'm delighted that so many trusts have actually submitted data to us, and only 7% have yet to do so. Where we haven't received any data or no one has yet spoken up to a Freedom to Speak Up Guardian, we're going to be going back to the trust to check that their arrangements meet the needs of their staff. My first case review in our pilot was into Southport and Ormskirk Hospital's NHS Trust. I made 23 recommendations, including 22 for the Trust and 1 for the CQC, relating to the use of fit and proper person review. And I hope that these recommendations will be valuable not only for those organisations but for all trusts across the country to incorporate into their speaking up strategy. My future priorities are to develop a quality assurance of speaking up cultures nationally. This includes personal development for Guardians and organisational development for trusts, incorporating speaking up into internal audit and external review via the CQC well-led inspection and National Guardian case reviews. We will continue to learn from the experience and expertise across many different sectors of the economy, and also to provide training. My request today is that NHS England Board notes my annual report, but also the appointment of your Freedom to Speak Up Guardians for NHS England and CSU workers to really role model the speaking up culture that we'd like to see across health. Thank you very much.
Thank you very much. I have no hesitation in inviting the board to endorse your report. But let's go into the issues around speaking up Guardians. Michelle.
Thank you very much for your report. I have a question particularly for Emily, and to what degree do you think NHS England is making good progress? And in particular, I'm interested in the number of people from BME backgrounds who are also speaking up Guardians.
Thank you. We have previously only had one Freedom to Speak Up Guardian, who's my predecessor. And what we've done in the last 2 or 3 months since just before I got here is to really try and broaden the involvement of the whole organisation in Freedom to Speak Up, including representatives from CSUs. We currently have 40 people who have said they would like to be Freedom to Speak Up Guardians going forward, of whom 24% are from BME background. And 11 of those people went through training yesterday, and we have further training sessions in December and January to make sure that we don't put people into position until they feel like they've really had the chance to think about what the role means, how they create the right time for it, the right support they're going to need to make sure they can carry out their duties effectively.
Thank you.
Thank you. This is really interesting. Like Emily, I very much agree that having a range of different routes for people within organisations to make points that they may find difficult to relate through the normal channels is very helpful. But having said that, I guess my experience is that in healthy organisations, the vast majority of issues that people come across in their working lives ought to be and are most usefully resolved through their line managers. So I guess my question is, how do we make sure that learning for line management is generated by this programme. And I was thinking particularly about the ambulance case study in our papers. And how do we make sure that the inevitable sort of administrative burden of speaking, of freedom to speak out up is sort of proportionate and doesn't get in the way of really empowering management and leadership within organisations to do a great job?
Yeah, I completely agree. Speaking up is a small part of the story. Listening well is the thing that really matters. And in environments where leaders and managers create the environment where people are happy to speak up and feel psychologically safe to do so, then the role of the Guardian is really there as a sort of supportive mechanism. So in terms of training for managers, there's been some really innovative work that's being done by Guardians who are helping managers to create the right time and space, because often time is a big issue, but also so that they can then escalate those up to their managers and that they'll get a good reception as well. I mean, from a position of the administrative burden, we see the Guardian role as not doing everything themselves. They need to work in partnership with the res team in their trusts and the staff side with the complaints and incidents, the Guardian of safer working hours, etc., so that they can really understand where the problem areas are in the trust and actually be proactive in going in and supporting positive cultures by sitting in on team meetings. And the feedback that I have from chief executives is that they found this really, really helpful because it helps them understand what's actually happening in the front line of their organisations.
Victor.
I just wanted to ask this is good stuff, how are you working with the Workforce Race Equality Strategy and Yvonne Coghill?
Yeah, so Yvonne and I have regular communications. I'm part of the stakeholder advisory group and she's part of my advisory working group because we can see that we're receiving very similar types of correspondence. In fact, there was a very large racial element into the first case review that we did at the Southport and Ormskirk. And, you know, I'm hearing stories from across the NHS which are very worrying in terms of racial elements where people feel less able to speak up, and that really echoes the findings that Sir Robert Francis identified as part of his Freedom to Speak Up review for all vulnerable groups. So from that respect, Yvonne and I are working, you know, really carefully together. Where there are trusts where we feel that the res team could really help to support the organisation, we're encouraging them to invite her team in as well. So I do think that there's a lot of joint working that we can do nationally, but that doesn't detract from what we expect the Guardians to be doing locally in their trusts as well, with the res teams, you know, in individual organisations.
Good. Well, Henrietta, thank you. Did you want to come in, Joan? No, you raised your hand. I'm so used to sensitive reading of body language around the table. Henrietta, thank you so much. I think it's immensely valuable to have a national Guardian for speaking up on this basis. I think you will understand from us the commitment of this board to the enterprise. I think in context also with the point that you and Joanne made, which is the relationship to line management and how this works to ensure that people have an opportunity to step out and to speak up where that system doesn't work. But we endorse your report and thank you so much for spending time with us this morning to present it in person.
Thank you very much.
Thank you.
Well, we should turn at this stage to research. I'm very pleased to welcome Professor Chris Whitty, who is the Acting Government Chief Science Advisor, but also is the head of NIHR, National Institutes for Health Research. And first of all, to thank you and for Ian to the extent of how much cross-working there has been in developing this document. I'm going to invite Ian to introduce it and then invite you, Chris, to speak to it as well, if you will.
Thank you very much, Chair. Today I'm inviting the NHS England Board to commit to 12 practical actions to support and apply research. We've joined forces with Chris and the NIHR, and we've taken the insights and suggestions of many colleagues in the research world, in life sciences and in the NHS, not least those set out in Sir John Bell's report earlier this year. So Chris, I think, will illuminate the wider research context for us, and then I'll highlight some of the specific actions. Chris, please.
Just to make some two obvious points and one possibly slightly less obvious point. I mean, the first obvious point is research is absolutely essential to both the current and future NHS. And if you look at the stunning improvements that have been in things like cardiovascular disease, they're all based on good research, a lot of it through the NHS. Future things like mental health, where we've really flatlined for a long time, are going to depend on future research. So it is a central part of what we need to do. And we know that patients who are involved in research do better, and we know that staff are motivated to be part of it. So I think it has many benefits, and I think everyone around the board would agree with those. I think the second thing, which is possibly less widely recognised, is quite what a powerhouse the NHS is in terms of research globally. And if you look at all but one trusts are involved in research, 45% of GP practices are research active. And if you look at research coming out in the major medical journals, the UK, just taking the research funded by the two major government funders, NHR and the Medical Research Council, has more clinical research coming out through the major journals than the NIH in the US, which has a budget 10 times as great. So we are both incredibly productive and very efficient at what we do, and this is the kind of research that would improve patient benefit in the long run. And we're also leaders in involving patients and carers in decisions about what research is undertaken. So there is a very strong link on that. I think that the but in that is that there are still some bits of the system which are complex and make research difficult. So you have researchers who wish to do it, funding available, and patients who wish to take part, but the bureaucracy gets in the way. And some of the systems we put in place are in fact quite baroque. And part of the aim of what Ian and his colleagues have suggested, with strong support from us, but I want to be clear this is very much NHSE led, is to improve on that. And the second is to recognise that some of the research has not been fully systematically engaging with the priorities of NHSE. So it has been good at the priorities of the clinicians, but not so good, I think, at the priorities of the system. And research can significantly improve the efficiency and effectiveness of the system over time. So what we wanted to do is to try and balance those two sides of the equations, and those are the proposals that Ian and his team have come up with.
Thank you very much, Chris. So I will briefly canter through the 12 actions flowing from 5 objectives. So the first is about simplifying the baroque research bureaucracy that Chris alluded to. So with the NIHR and the Health Research Authority, we're consulting on 2 different specific proposals. One is to manage excess treatment costs better, and the second is to eliminate delays in setting up multi-site trials. So instead of repeated negotiations between sponsors and trusts for exactly the same trial, we could have a single coordinating service which assesses and determines fair and binding prices using a standard method and standard contract. And what we're proposing is to mandate that across the NHS, working with the NIHR. It would speed up research development times, whilst also cutting transaction costs for everyone. And a couple of days ago, I was talking to an industry leader who said to me that this may sound like a small technical change to you, but it will be a significant improvement to us. Secondly, as Chris mentioned, we're looking to ensure that NHS England and the commissioning system, working with providers, gets better at articulating both national and local NHS research needs better. Thirdly, we're looking to improve the research data architecture. So with our partners, including the British Medical Association and the Royal College of GPs, we're supporting and driving faster uptake of the clinical practice research data link, and we will also help establish local care records that are research ready. Fourthly, we will lead advanced research programs through the next stage of our work on both genomics and also artificial intelligence. And finally, because if we're going to realise the benefits that Chris has alluded to around research informing practice, we need to drive faster adoption of proven and affordable research and innovation in the NHS. And we will do that through our own functions in NHS England, such as the work on specialised commissioning and drug procurement, through our national improvement programmes on mental health, on cancer, primary care, urgent emergency care, and through the 15 academic health science networks which we are backing to become the core NHS innovation architecture. And finally, working with the Office of Life Sciences, which spans across the Department of Health and BAYS, as well as Innovate UK, we will review, simplify and strengthen national innovation programmes, of which there are many, so that they can better combine the pursuit of NHS sustainability at the same time as economic growth. So I invite the board to endorse our commitment to a research-rich NHS and a flourishing life sciences sector, and to commend the joint statement.
Right, thank you, Ian, and thank you, Chris. Let me invite questions, comments from the board. Michelle.
Thank you. Thanks very much for the paper. 2 points from me. I'm really interested to hear more about the citizen and patient engagement in research, and in particular whether you're using the James Lind Alliance process as part of establishing not only research questions but citizen engagement throughout the whole research process. And then the second point from me, particularly for Ian, if you could talk us through how the major impact goals are driving the research strategy for NHS England, and when does that process come together in terms of really clearly identifying the research questions for our national programme and aligning the resource and processes behind that? So it's kind of the top-down as well as bottom-up side of setting the research strategy.
Shall I take the first one? I mean, on that, the NHS and NIHR are seen as the world leaders in this area. The James Lind Alliance, which you referred to, which is groups of patients and other members of the public with strong interests, helping set the agenda, is something which is supported by NIHR and very much underpins decisions that are taken at a clinical level about what we do. Where that is obviously less effective is in the kind of more general questions around system architecture, which are the ones which are of importance to the NHSE as a body. But for clinical interventions in particular, patient-public involvement is absolutely central to the way we work for obvious and very important reasons.
So, and what we'll be doing with Chris and his team is, rather than NHS England separately having a parallel process to the work that NIHR is doing to engage patients and citizens, we'll obviously be looking to join forces as we produce our statement, one of the actions to do so by next April, of our core research needs. On your second question around major impact goals, within each of the clinical programmes, Chris and I have been working with our different national programmes to work through what are the main unresolved questions and challenges that they have, including some of the perennial ones. We've gone through diabetes, we've been through urgent and emergency care, mental health, primary care, specialised services including rare diseases. We've got one of those seminars left which is on cancer, and from that we're trying to crystallise those questions, to map them against what pre-existing research exists or is in train, and to then come up with a prioritised ranked list of the obvious areas for further research. We're interested in making sure then that the research that's conducted is based on clear method that is reproducible and has clarity of the benefits that arise from it. And one of the specific actions we have here is in relation to one aspect of those benefits. We have the triple aim we pursue, better care outcomes, better quality care, better value, we clearly need findings against all three of those domains, and one of the observations that Chris and I are kind of noting is that there tends to be a gap in relation to the last of those around value. And so what we're looking to try and do is to make sure that we get better at commissioning and integrating within research findings understandings of economic value and costs and cost changes within the system, because if we get that right, and if we can demonstrate that innovations are not only better for outcomes and quality of care, but also can reduce costs, and we've seen this in many other sectors, then we will be able to drive, I think, systematic adoption much faster.
that work? When do you think that first iteration will come to conclusion?
So on the our research needs, we're making a clear commitment to publish that in April 2018.
Okay, thank you.
John. Malcolm, I should start by saying that I'm one of Chris's senior investigators, so I should salute my other boss. In that role, I led for 5 years the CRN for genetics and a special group trying to advance rare disease research. And just to emphasise the point that David picked up earlier about bureaucracy, one of the things blocking rare disease research was that you had to get consent from every hospital before you could start, and a 2-year project could be used up getting permission. So we were actually, with NIHR support, able to actually establish what we called the Musketeers Memorandum, where if one leading trust said it was okay, all the others trusted it, the rest of them to agree, and we were able to get rare disease projects through in a week, and it transformed our recruitment of trials. So this can be done, but it needs to be scaled up. The other thing I mentioned yesterday in our private meeting was that the Great North Care Record this week announced that it's now moving out to inviting all the people in the North East to become data donors and to actually positively consent to be part of clinical research. So I think that's another initiative. What I wanted to particularly mention, though, was excess treatment costs. It sounds a very obscure point, but I've just had to live through the dilemma of this because we're doing an aspirin trial. And one leading hospital was going to pull out of our trial because they said they couldn't afford the aspirin for the 53 people who had been recruited in their hospital. And we had to actually go to the Department of Health with a special plea to get funding for the aspirin to give to all the hospitals, which was an enormous, elaborate process. We then had one senior pharmacist in another trust saying that it's not enough, that the support were being given. So my manager pointed out that their trust would have to pay £109.25 extra. And on that point, the pharmacist agreed that it was probably unreasonable to complain. But the administrative burden of this across every hospital in the country is enormous. So we really do need to grapple with it. I should finish by saying that Newcastle has the highest volume of research studies of all the trusts in the report. I couldn't fail to mention that. But, so it isn't important. So excess treatment costs are an issue, but we do need to streamline it. It is ridiculously burdensome.
We look forward to you growing that volume.
Absolutely. Right, okay. On the excess treatment costs, is there anything you need to add to following John's comment?
I think that was a very good point.
Yeah. And what he was able to do with the CRN, you would propose with multi-site trials to be able to drive across the country. Jane?
So I really welcome the work and the actions, and I guess just a plea really that when we do look at this, we consider the whole gamut of research and actually include multi-professional teams in that. For example, I've got a round table with the Council of Deans in a few weeks looking at research applied to nursing and nursing practice. It'd be fantastic to be able to ensure that we've got all Royal Colleges and all different organisations involved as well as the medical ones.
And as you know, but just to assure the board, the NHS and NIHR are the largest supporter of this in the world by some distance.
Exactly.
Across
so
all the allied
things. It's just making a point, but I completely support what we're doing.
Thank you. I've got Noel and Wendy. Noel?
I should say at the outset that my own letter, or NHS Digital's letter to Sir John Bell on our 10 action points, is very closely aligned to what you have here, Ian. But my thought is that as we open up this new frontier to usher in this new era of using data and data infrastructure, which is, some of which is being provided by NHS Digital, so we're seeking to sort of bring this flotilla of history into much more of an aligned convoy. And I'm really interested to ask for your thoughts on what are the coordination mechanisms, what's the alignment mechanism that is really going to bring this diaspora into an industrially fit and cohesive complex that will deliver what we're asking for here. Because some alignments are relatively easy. NHSD with NHSE on the infrastructure is relatively straightforward. Some of this is quite new. What are your thoughts around how we coordinate this?
I think it's a great point, Noel. And if I can particularly point to the 12th action, which is around how do we review and potentially simplify lots of the different innovation programs. We have a very large number across different national organisations, and I've been discussing with the leadership of Innovate UK, with the Office of Life Sciences, with the Minister in the Department of Health, Lord O'Shaughnessy, with NIHR, how do we have a joint piece of work that tries to connect what have historically been quite separate silos, many of which have been effective in their own terms, but arguably failed to achieve more than the sum of their parts. Linked to that, I've been talking to the Minister and to OLS about having a tighter core coordinating mechanism for driving lots of those actions in relation to life sciences. And indeed, there was a meeting earlier this week as part of the cross-system work, the Ministerial and Industry Group, which is chaired by the Secretary of State with industry colleagues to create a wider life sciences sector council and revised governance which will seek to achieve exactly your goal. I think the wider observation here is that we have a vast number of different people doing different things at the moment, and there is a great opportunity to get better value and impact from them.
Can I just add, though, would not want the board to get the impression that this excellent work by Ian and his colleagues will solve the data issues. No. I think there are a range of data issues that still need to be resolved, and I think we probably may need to come back to you in a different guise, absolutely in collaboration with you around those. This solves a lot of other problems, but I think the data ones are still to come.
I think the whole NHS and DH community's got to get the whole data thing sorted out and fast, and that will be, I think, a new avenue for research. So I've got Wendy, Moira and Joanne. Wendy.
Yeah, fully agree on the data point. Another limiter I wanted to ask about, I think this is a brilliant initiative and the report's really clear. We have great science and great research in this country because we have great research scientists. One of the things I hear about workforce is that there's a lot of pressure for our clinical scientists about what they need to be doing in times of service pressure and actually spending time on research. How are we creating an environment where our most talented clinical research scientists can make sure to do that and don't get pulled off to the other things we think are important?
I mean, there's a mechanistic answer and there's a cultural answer. I think mechanistically there are quite a large number of schemes available, and I think the creation of NHS, which I was not involved in, although I'm now involved in helping to run it, made a big difference in terms of the training grades and the non-medical clinical ones, to go back to Professor Cummings' previous point. There is a little bit of problem with joint clinical and academic posts, and they have probably taken a slight backward step over the last 10 years. Nevertheless, we're strong there. I think mechanistically, I'm not actually at this point particularly gloomy. I am concerned, however, culturally. If you look across the sweep of medicine and medical disciplines, including the non-medical, other clinical disciplines, some of them are really well represented and they can get research done very easily. Cardiology, cancer, infectious diseases. Others, which are very important, for example, care of the elderly, people express very considerable problems. Now, in my judgment, a lot of this is cultural within the professions, at least as much as it is to do with the systems in place. And I think one of the things we need to do is to look at those areas where people are reporting problems and say, let's fix this as a joint thing between the professions and those who are providing support. Because I don't think this is just a government and structure system. I think this is also a cultural thing.
Thanks, Malcolm. I just wanted to follow up on Michelle's question, really, and it is about the governance of the NHS priorities. You talked about them being published, but where does the governance lie, and is it with NHS England? And therefore, will this board see it before it's published?
Yes, it is within NHS England, and certainly we can do that.
And I wanted to follow up just linked to that last point, because it does seem to me, I was very pleased to see the reference to mental health in the example that you gave. But if we applied a parity of esteem lens to the research, I'm sure that mental health and other areas, as you mentioned, the care of the elderly, would be highly underrepresented. And are we taking that very seriously, really, as a place where we can influence?
Yes, so I think that we are taking it very seriously. I think that the answers are not straightforward, because if you've got a weak field, tipping money into it actually is not the answer. What you have to do is build the field up steadily. And taking the case of mental health, I think one of the things that's very striking is that if you took out about 4 institutions, one of them quite close to here, there would be almost no serious mental health research in the UK at all. It's heavily concentrated in a very small number of places. If you're in the catchment area of those hospitals, then actually the parity of esteem looks pretty good. If you're in other areas, it looks really problematic. And I think we have both a sectoral area but also a geographical need, because we would wish all citizens of England to be able to be involved in research irrespective of what their area is.
Thank you. I think anybody reading this can't fail to be struck by the sheer number of entities, networks, partnerships, institutes, collaborations. And I guess where I see that kind of complexity, I see difficulty and cost. And if we look at just one little bit of that, because we had the benefit of a presentation recently on AHSNs, relatively small individually, relatively small organisations, relatively complex even in themselves, each having a board and having representatives of lots of local players, and having created a work on, I think they were talking about 200 innovations. So I guess my question is about how confident are we that what we have in here is going to create the sufficient alignment and clarity to enable prioritisation and focus around the work that you're doing?
I'll give an answer in principle, and Ian might want to give us a detailed one. The answer in principle is I completely agree with, and I think anybody who looks at this agrees with your starting position, which is the system is too complicated. And actually one of the things this is trying to do is trying to strip some complications out. There are many more, and you have to kind of just take them as they come. But I think both with looking at the whole system and looking specifically at NHR, which is the bit that I'm responsible for, we totally agree that actually making it simpler is the right answer, because otherwise you have lots of joins up which lead to inefficiencies and lead to things falling between the cracks.
And specifically on AHSNs, what the 15 have committed to do is to come together as a single national network of networks and to work through, you mentioned the 200 plus innovations, to work through what the best buys are that they will collectively pursue. And so we will get a very clear list back of the different innovations. So if you take patient safety, there's 40 or 50 different patient safety initiatives being run out of the 15 patient safety collaboratives. So Deborah Evans, who joined the board, is the leading managing director, and she's chairing and convening all 15, working with Celia Ingham-Clark from NHSI to come up with the list of the best patient safety initiatives. That may well include Precept, for example, which Deborah presented on. And then we'll get the agreement of all of the AHSNs that they will then drive that. And I think we will end up, for the first time, in having a systematic process in co-curating some of those high-impact changes.
Good, right, thanks. Well, we had a very good discussion. I'm going to invite the board, first of all, to approve the joint statement between NHS England and can I say personally, Chris, the way in which NIHR is willing to think across the whole of the NHS in this way is hugely valued by us. So thank you for joining with us on that. And then secondly, to approve the launch of a consultation around excess treatment costs and multi-site trials. Happy to do that? Fantastic. Great. Thank you very much. At this point, I've got a strategic question for the board. Okay. You mean we should press ahead with business, or we should take? See, I can't read the body language at all. Okay, we'll take a 5-minute break. Thank you. This is the resumed meeting of the Board of NHS England. I'm going to now turn to item 9 on the agenda, which is NHS performance and progress on the implementation of next steps, and to invite Matthew to present the paper.
Thank you, Chairman. It's exciting to start the second half of our meeting, then quite along as the first.
I would like to focus primarily on this on urgent emergency care as we run into winter. So I think the first thing to say is that across October and coming out of the summer, the NHS has maintained its performance. It's been stable. We've been putting a lot of work into the redesign in the preparation of winter, and we've maintained a position where more than 9 in 10 patients were being seen within the 4-hour target. We are beginning to see the pressure of winter hitting during November, and it beginning sense that it's beginning to impact on performance. Which is why it's so important that the winter plan that we have in place lands. We have 122 trusts who have now got our streaming program in place in their A&Es, so that patients who don't know need to go through the A&E but need to go speak to primary care services are being streamed to primary care, and they will all be in place. That'll be in place in every hospital by the end of the year. The work on getting delayed transfers of care patients, long-stay patients who are wrongly being cared for in hospital and need some other sort of care out of hospital. We've managed to release about 1,000 additional beds. That's on our challenge to get to releasing 2,400. So we're getting towards the halfway point on that, but we have a lot of work still to do on there. But thanks to our colleagues in social care who are making a significant contribution, and we are seeing capacity being created, although there is much more to do. 111, we are now at a point where nearly 40% of the people who ring 111 get to speak to a clinician through that service, are triaged to a clinician. The target was 30%, and that is almost doubling on where we were last year. So increasingly more people are getting the advice that they need on the phone, either to self-care or that they can be cared for without needing to go to hospital. And I think 111 is increasingly providing a very important part of our urgent access service. And the work we've been doing around urgent treatment centres, we now have 104 have been designated against the standard of consistent services that people can use, and increasingly those urgent treatment centres you can be booked directly for an appointment into if you ring 111. So the service is coming together. So there's a lot of work going on across the NHS to put the winter plan in place. I would like to just touch on and ask for the public's support in preparing for and managing winter well. I think Simon mentioned at the beginning the importance of flu vaccinations, and that we are doing better, more vaccinations than we had at this point last year. But there are still a lot of people who don't get themselves vaccinated and who have that opportunity. And so I would urge that people go to their GP or go to a pharmacy and get themselves vaccinated. Care workers, people who are either working in care homes or people who are working in people's homes caring for the elderly, for the first time we have said that we will fund their vaccination. So the £10 million that we've made available to make that happen, I would plead with those people to take advantage of that offer. This is not just about whether you personally avoid missing days off work by having the flu. It's that if you're dealing with either very young people or frail elderly people, if you get the flu, you put other people at risk. In the same way as we're asking NHS staff to get themselves vaccinated, not just for themselves and not just so they don't miss time off work, but because they're dealing with vulnerable people. It's part of your kind of professional obligation to get yourself protected in order that you are not a spreader of the flu. And it would be a tragedy if people were doing a wonderful job caring for people except that they gave them the flu. So and 30% of flu is transmitted by people who don't even know they've got the flu. So it's not just a question of, well, I won't go to work if I feel ill. Get yourself vaccinated and help protect the people that you work with, your friends and your neighbours. And I would say that to the general public as well. You may think that you are fit, healthy, and will tough it out if you get the flu. But if you're seeing young relatives or old relatives across the Christmas period, don't give them a present and the flu. take the opportunity to get yourself vaccinated and protect the people you're with. And if you do that, you help support the NHS in using its resources properly, but also you're helping to protect the community that you live in. So I think we need people to do their bit around vaccination and reduce the probability that they are going to get the flu themselves. I'd also ask people to, as we have seen increasingly during this year that people already are, to use services wisely. Don't go to hospital if you can go to a GP. We will have more GP appointments available across the Christmas period this year than we ever have before. Contact your surgery as usual over Christmas. If they are not open, they'll tell you where you can get an appointment, somewhere local to you. If it's not in your practice, it will be nearby. We've put a huge effort into making sure that GP services are fully available. So A&E isn't an alternative GP service. A&E is for people who need access to accident and emergency. If you're not sure where to go, use the 111 service. They can give you advice. If you need to speak to a clinician, you will get to speak to a clinician. And use GPs wisely as well. In October, 50,000 people a week were going to see their GP with the common cold. If people would use GPs wisely, that would be 50,000 appointments that somebody who actually needed to see a GP rather than going to a pharmacy and go and buy yourself some cold medication or just wrap yourself up warm. But GPs aren't going to give you antibiotics for a cold because they don't do any good, so there's really no point in wasting your time and wasting the GP's time by going along and saying you've got a runny nose. So you feel as though it can't be happening, but 50,000 people a week is a lot of GP time. So let's help GPs out by allowing them to use their time more wisely. We have invested in primary care this winter, and we have invested in primary care across this year. So our primary care strategy, we're £81 million ahead of our planned additional investment in primary care. Nearly half the country have access to evening and weekend appointments through our extended access programme, and by March in 2019 that'll be 100% of the country. So we are extending our primary care services. So I think there is a package of care to support people across winter, to not overwhelm A&Es with work that shouldn't be there, so that our hospital staff can do the work that's needed to be done, and we need the public's help in making that true. Just glancing one or two other highlights across the 5-year forward view, I'd just like to touch on cancer. We're hitting all of the major targets except for one, so we're now at 94% of people seen by a specialist within 2 weeks of referral against a target of 92%. So I think that's tremendous performance. We're working really hard to hit the 62-day from referral to treatment target. We're now at 82%, which is an improvement. Still a little way to go to hit the 85% target, but I think it's just worth noting that as we've turned our attention to that target, there are now 2,287 people fewer waiting over 62 days for treatment. So that's a 25% reduction in the long waiters since May this year. So that's, as the NHS focuses on hitting the target, it's part of that is focusing on people who've waited too long and getting them treated, and that's a very significant shift, and I think we should be proud of that and proud of what the NHS has done. We're on track to hit the mental health standards as well. So I think across the race, under a lot of pressure, the NHS is doing well, but we now go into the most difficult time of the year.
Comments, queries on Matthew's report? I've just been reading a book about the last great flu epidemic 100 years ago in 1918. Which caused more deaths.
Before my time, Malcolm.
Only just. That caused more deaths than the First World War, possibly combined with the Second World War. So fortunately, we know a lot more about it nowadays. But the vaccination issue, I think, is an important part of public protection for the very reasons you've outlined. Joanne.
So this. Obviously, Matthew is another update for us, and I think we probably expressed the view that's shared by many that we're all very impressed with the concentration and the quality of the planning and the work that's going into managing winter. So it's great to have an update for it. And I think it's a really impressive brigade of work. I have a couple of questions. One is that for very many people these days, the first stop when you have a question or an issue that you want help with is to go online. So can you tell us a bit more about what there is on offer for people with what might be an urgent care need over the winter period? And the second thing I wanted to ask you is in relation to the 111 service. I mean, as you know, one of the things that distinguished 111 from its predecessor is that 111 wasn't conceived as a service that was meant to reduce demand on face-to-face. It was about sending people to the right place rather than meeting people's needs in toto. So it's great to see the clinical input going up, and I think that's obviously reached a significantly high point. But it is, after all, an input measure. And so my question is, are we measuring and are they reporting on the number of calls where the call is, as it were, closed and the caller's need is completely met within the 111 service? And how does that look, and how are we helping them to not just provide clinical input, but to provide, if you like, completion and meeting the person's needs without going somewhere else?
Thank you. That's a very good question. You're quite right that when 111 was created, it was primarily a triaging service to advise people where to go. We are changing that model, so kind of in flight we are rebuilding the aeroplane, and part of that is precisely that more people should get to speak to a clinician. We are trying to move to what we call a consultant complete, as in you ring up, you speak to somebody, and they can actually solve your problem for you on the phone, which means we have some things to do around technology which we haven't got in place, and there's a lot of work going on at the moment. So, for instance, if you ring up and the conclusion after you've spoken to a clinician on the phone is that you need a prescription, we need to make sure that they can e-prescribe you, give you an e-prescription then and say to you, if you go to your local pharmacy, you can pick up your prescription, not you need to go to your GP and get them to write you a prescription for this, because that doesn't solve your problem. Similarly, if the answer is, no, you really do need to see a GP face-to-face, we want to be able to, from 111, to give you an appointment to go and see your GP, rather than send you back in to try and get one for yourself, because one of the things we know from tracking the data is that if you say you really need to go and see your GP, a proportion of those people don't then go to their GP, they go to the A&E department. So we need to give them with and at 3:30 tomorrow afternoon your GP will see you. So we have some work to do internally with 111 to make more things completable, and that work is going on at the moment. But part of this is also what can people do for themselves? So can they do by going online? So we're making it so that the questions that you would be asked by a call handler, you can do yourself online. You don't actually need to speak to someone. And if the conclusion from that is you need to speak to a clinician, you will be able to be routed through to go into the queue to speak to a clinician and not have to repeat yourself to a call handler, but also to route you to the huge amount of information that we have within NHS Online, which has lots of information about self-care, about both how to look after yourself if you've got a cold, but all the way through to much more serious treatment. And we're doing that. We've also been moving NHS Choices, which was the first in the world of its type when it was launched 10-15 years ago, onto a new platform, so it works better on an iPhone, it works better on a Galaxy, rather than being designed as it was originally to run through a traditional web page off a PC. We've moved about 40% of NHS Choices into an environment that now runs well on a mobile device.
Thank you, Matthew. Anything further from Matthew? Myra.
Very briefly, just to say what good news it is that we're offering free vaccinations to care staff. This is the first time, Matthew said. I hope it won't be the last time, and it will be assumed to be, so that it can actually be announced to those staff earlier in the year.
Yes, good point.
Yes, thank you.
Jane?
Just really quickly, I think Matthew did a very passionate plea about the flu vaccine. I just really wanted to highlight that if you do anything, it's the children. Our Chief Medical Officer in the Department of Health will often calls them super spreaders, and actually that's really critical. So getting children vaccinated, and as we are, in current cold weather, we've got cold weather alerts that are already out across the country. That does have an impact on people's health, and can lead to increased emissions. So keeping warm, layering clothes, making sure that people have plenty of hot drinks, hot food, etc., is actually really critical. And looking after neighbours and relatives if they're not able to get out in the cold weather is really important.
It's an atmosphere that has penetrated this room today.
It is cold.
As you can see by the scarf.
Indeed, indeed. So, any further points for Matthew? No, Matthew, thank you very much for that report. Let's move on to the finance report. Paul.
You're welcome. So, as people will have noticed, the snow has cleared. Elephant and Castle is giving us the closest it gets to a blue sky on a November morning. And someone has turned up the temperature in the room, despite the scarves sitting around. So the stage is set for an upbeat financial report, in which respect I fear I may have to disappoint you. So what you have in front of you is the month 7 financial position. You'll recall the last time that we met, I indicated that we're carrying out an intensive review with our regional teams to establish in particular the extent to which the CCG risks of about 520 million, as we saw them at that point, were going to translate into actual overspends by the end of the year. I said then that it was my view that these risks were very real, and indeed that the review, which we completed a couple of weeks ago, has confirmed that assessment. Some of these risks you've seen have now moved into the core forecast, which, as you can see in the local net expenditure section of Appendix A, shows an expected overspend of 225 and a bit million in the CCG position, offset by a 60 million underspend on quality premium. The rest is in the net risk, which is reported by CCGs alongside their core forecast, which remains stubbornly at just over 550 million, even after all of the mitigating actions which I described at some length at our last meeting. The two factors in all of that, which I drew your attention to last time, remain significant drivers of that position, and of themselves would lead to about 80 CCGs being at serious risk of overspending against their plan. First of those was case mix, the cost per case of admitted patients in particular, which remains a major pressure, reflecting both real trends in the seriousness of the condition of patients arriving in our hospitals, and secondly, the additional richness of coding now available to hospitals to reflect that in their billing. And the second thing was then the efficiency delivery, which, despite an expected increase of 600 million in the level of commissioner efficiencies delivered compared with the record levels achieved last year, is likely to fall significantly short of the very challenging plans set for the year, as you can see if you want to look at that in more depth in Appendix D. So two issues common to last time, still there this time: case mix, the acuity of the cases coming into our hospitals, and despite Herculean efforts, I would say, by CCGs and indeed the specialised commissioning teams, massive increase in the efficiency delivered, not quite as massive as we had in the ambitious plans at the start of the year. So all of that is common to what we discussed last time, and I wasn't going to go any further with that discussion. The new element in the picture is the emergence of a major unbudgeted pressure over the last few months on the reimbursement of drugs to the community pharmacy sector, driven by quite serious supply issues in the generic drug market. This is not something we've talked about before because it hasn't really been necessary, but there is a system for so-called concessionary pricing which kicks in when the market gets into difficulties of supply to ensure continuity of supply. It's a routine process administered by the Department of Health, and the current problem has built up slowly across the year. But to give you a sense of this, in the month of October alone, we've seen more additional cost in this area than we saw in the whole of either of the previous 2 years. So a very substantial ramping up of the problem. So as you'd expect, we're working very closely with the department to bring this spend, which should by its nature be temporary, back into line as quickly as possible. In the meanwhile, though, we've had to reflect it in the risks that we're showing for the year, which is the main reason why the combination of forecasts and net risks has increased in the way that you can see in the reports. There are two primary questions that leaves us with, really, as a consequence of all of that. The first is, can we still deliver financial balance this year in the commissioning sector as a whole? And the second, equally important, is what does it mean for our plans for 18-19? On the first of those questions, we've been making progress with identifying largely one-off savings in our central budgets, and we're delaying all but the most critical expenditure wherever possible. But the drug stock issue really has set us back quite significantly in that endeavour. As the report sets out, we're still 366 million short of solutions if all of the CCG risk I described actually comes about. But this is work in progress and will obviously continue to bear down on the underlying operational issues and to search out further potential mitigations. And I would, of course, remind you that all of these numbers, including that imbalance that I've just described, exclude the 560 million of system risk reserve that we set aside at the beginning of the year to cover additional risks. So the risk of us not fulfilling our core statutory duty to break even as a commissioning sector, I think, is relatively small. That isn't the issue. But clearly we would have wanted to and are still doing our very best to get to break even without dipping into the system reserve. On the second question, which is what does this mean for the 18-19 discussion that we had earlier on, I am much more concerned because most of the savings which will enable us to reach whatever position we do reach at the end of the year are one-off in nature, whereas there is an underlying and, in my judgment, a persisting deficit in the CCG sector, which even when I strip out all of the temporary factors, both positive and negative, still feels to me to be round about the 500 million mark, and that I think you will have picked up in the discussion that we had about 18-19. That is, of course, tantalisingly and coincidentally roughly equivalent to the system reserve which we set aside in 17-18 and will need in 17-18 both for our own position and for provider sector risks. But one way or another, and we talked about this a bit earlier on, it will need addressing through the difficult choices that we discussed in the context of the budget and plans. That's really all I wanted to say, I think, today. We'll clearly need to come back on repeated occasions to how that is moving forward and what we're going to do about it, both for this year and for next year.
Thank you, Paul. We're obviously going to want to keep a very close eye on that unexpected surge in drug costs. I think we're all pretty worried about that. Okay, any further questions to Paul, please? Okay, thanks very much, Paul. We move now then to item 11, which is the reports from the board committees. First one from Commissioning Committee, and David, I think you've got a proposal to put to us.
Yeah, so the report I'll take as read, other than perhaps just to highlight a couple of things. One is that we are seeking to refresh the remuneration guidance for CCGs, which as we start to see more mergers, more activities, needs to reflect that, and also the learning from some of the issues that we've had in the country. And secondly, that we have approved a number of proposed CCG mergers, and again, I think we would probably expect to see more of those as time moves on with ACS's STPs coming together. In terms of the delegation, the board will be aware we've been having some delegating primary care to co-commissioning with CCGs. That's been an ongoing process now for I think 3 years. A number of CCGs have applied to take on delegated commissioning from the 1st of April 2018. Given the way that board meetings work, etc., we need to crack on with that. So the proposal, Malcolm, is that a request that the board delegates authority to the commissioning committee to agree which CCGs should be supported going forward. We'll consider that, and I will provide a written update on where we got to on the February board, and the approach is in line with our standing orders and scheme of delegation should the board agree to delegate it to the commissioning committee.
Thank you, David. Is the board willing to agree to that delegation?
Agree.
Yes.
Thank you.
Thank you. Moira, investment.
Nothing to add, Malcolm.
Noel, specialised services.
No, I have nothing, Malcolm, to add.
Joanne, audit and risk.
Yes, thank you. I just might say a brief word about the two audit and finance fora that we've recently had with CCG, primarily audit chairs, which is a semi-annual event. I think they went particularly well this time round. I wanted to thank Matthew and other colleagues from around the organisation for taking the time to talk to CCG audit chairs, who are a very important group. It was also really nice that we had Richard Douglas, who's my counterpart chair of audit at NHS Improvement, came along and spoke to the London group, and I think that was appreciated and a very positive signal of us working collectively and in a greater alignment going forward.
Good. Thank you very much. We turn to any other business. I have one item. Are there any other items? Apart from noting the date of our next meeting on the 8th of February. I just wanted to underline what I said in opening about Bruce Keogh. And Bruce, it's been a fantastic record of achievement. You've served this board, I think, not only with great professionalism, but also, as we experienced this morning, with sheer power and passion. And all of us owe you an enormous amount for your contribution to our success so far. I think everybody would want to join me also in wishing you and Birmingham Women's and Children's Hospital all the very best for the future, and hope that we'll keep in touch.
That's very kind.
Thank you very much. I'm now going to ask the board to pass the usual resolution, and we move into private session. Thank you. The formal meeting is closed. Thank you.